All right. Welcome to Renegade Research Clinicians Roundtable. If this is your first time with us, we are a nonprofit, patient and caregiver-led, decentralized research organization, and we focus on infection-associated chronic illnesses such as ME/CFS and long COVID. We started this Clinicians Roundtable with the goal of having expert clinicians share their knowledge with those who want to help our patient population, and that way we can expand the pool of clinicians available to treat us and help us improve our quality of life. Most of you know us best from our largest project to date, Remission Biome. As a nonprofit, our work is funded by grants and private donations. Please visit the Remission Biome website if you're able to contribute in any way. On the website, we also have a handful of affiliate links from products that we use on the Remission Biome protocol or that we highly trust. This is not a suggestion to use those products, but if you already do, purchasing through our link will give you a generous discount as well as a small donation to our organization. More importantly, even before we had any funding, our wonderful team of volunteers move the wheels of our organization, as well as our limited number of staff. All of us have a personal interest in advancing research and care of infection-associated chronic illnesses. I am Isabel, Renegade CEO. Our founder, Tess, could not be here today, but she sent you all her love. And we have part of our team today with us, helping us make this possible. We have Rochelle, who is in charge of this webinar and helping us navigate through. We have Nick, who is the lead of our research. We have Michael today with us, and we also have our clinician advisor, Dr. John Houghton. If you haven't seen the presentation that he did before, I really encourage you to go to the Remission Biome YouTube channel and take a look at that, as well as the two previous presentations from Dr. Afrin. Today, we also have our volunteer extraordinaire, Ellie Boreas, and she will help us introduce the rest of our guests. So thank you and welcome everyone for being here today.
Hi, thank you, Isabel. Let me tell you that we have our guest panelist today, Dr. Alba Azola, an assistant professor at Johns Hopkins, who joined the chronic fatigue clinic there at the Children's Center, founded by Dr. Rowe in 1996, with the goal of expanding care to the adult ME/CFS population. And now to introduce our speaker, it is once again my pleasure to introduce Dr. Lawrence Afrin. Dr. Afrin practiced and researched hematology and oncology, but since about 2005, his work has come to focus on mast cell disease. He's done numerous lectures, podcasts, and interviews around the world on MCAS. He has most recently been developing an independent institute located in the greater New York City area for advancing care, research, and education in mast cell disease. It is called the AIM Center for Personalized Medicine, and you can read more about Dr. Afrin and even download his CV from the website aimcenterpm.com. Dr. Afrin's MCAS book, Never Bet Against Occam, which goes into more detail about the patients he has told us about and will tell us about more today, is available in audio, Kindle, and paperback. Dr. Afrin, please take us through part 3, the treatment of MCAS.
Oh, my pleasure. Thanks, Ellie. And I'm tickled you actually found the audio version of that book. It just came out about a few weeks ago. I don't think many people had known about that yet. Anyway, let me do the screen sharing here, make sure this is working. Okay, you folks getting my title slide?
Yes.
Okay. So let's set to it here. So the objectives of today's talk, try to understand the details of treating MCAS, and these are the pillars of treatment that I've listed here. Don't have any conflicts of interest to disclose, and just please note that any specific treatments mentioned here are by definition ACCME level of evidence C, consensus viewpoint or expert opinion, because there are no treatments that are yet FDA approved for MCAS, because the FDA, much like most doctors, doesn't even know MCAS exists yet. All right, so the outline of today's talk, focusing on treating MCAS. First, we'll talk about the goals, and then the general approach, and then steps 1, 2, and 3 through N, and wrap up at the end with a few miscellaneous items there. So after years of mystery, the first 2 talks gave about the overview of MCAS and the approach to diagnosing it. The patient now has a new diagnosis of MCAS, and it's usually years of mystery. The research is clear. These patients, principally because doctors aren't even taught the disease exists yet, most of these patients have been suffering with it for many years, often most of their lives, many decades before they actually get diagnosed. So they have a new diagnosis. What now? What are we going to do? What's the issue? What are the thoughts on prognosis and treatment? Regarding prognosis, not a whole lot to say about that at this point, because not a whole lot of study has been done yet. Not enough time to have studied it yet, actually. Again, remember the first case reports of this disease were published only about 17 years ago. Not much time for research to have been done, and I think it's fair to characterize all of the limited research done so far in this area as preliminary. But from what we can see so far, most people who have this disease seem to have a pretty normal lifespan kind of equivalent to that of the general population, which I remind my patients is a whole lot better situation than they got with an awful lot of other chronic diseases, which on average will cut the patient's life short. I mean, yeah, I'll be the first to acknowledge it's a chronically symptomatic disease until it comes to be accurately diagnosed and effectively controlled. But even if it takes a long time, I mean, even if it takes a few years to piece together the optimal cocktail of treatment for the individual mast cell patient, they're nevertheless highly likely to continue surviving to get to that point. And once they have an effective cocktail, they're expected to have a better quality of life for the remainder of a normal lifespan. So this is good news. I don't doubt that over time, more research gets done. We come to understand the science, the biology that's better, the testing gets more sophisticated. We probably will get to the point where we can start reliably identifying those relatively few patients who unfortunately are not going to have such a good prognosis. But for right now, this estimate of survival, roughly a normal lifetime, that's the best we can offer these patients, and it's good news. I tell my patients to take that to the bank and cash it for whatever it's worth. And also on this last point on this slide regarding prognosis, this is important too, at least in my experience. Not only are we blessed with already having a boatload of treatments which have already been found helpful in various mast cell patients, but in my experience, most patients who have this do sooner or later eventually identify some cocktail of mast cell targeted treatments, usually a pretty small cocktail, but highly unique to the individual patient. But most of these patients eventually identify some cocktail of mast cell targeted treatment that really does help them get to the goal. And I'll get to more on the goal in just a moment, but this is the overall natural lifetime course of this disease. It's always waxing and waning to some degree, but it tends to wax and wane about a baseline that tends to be pretty stable over long periods of time. But using whatever cocktail of treatments have been assembled at that point, and sometimes that's actually no treatment at all if the baseline level of symptoms is very modest. But from time to time throughout a mast cell patient's life, there can develop, not that there necessarily will develop, but there's potential to, the disease can fairly suddenly significantly escalate in the baseline level of misbehavior of the dysfunctional mast cells. And at that point, if the patient then needs to start re-exploring other mast cell targeted treatments to try to get the heightened symptoms back under better control, nothing wrong with that. And many patients in that scenario actually do enjoy varying degrees of success in that endeavor. But nevertheless, this is the overall, these escalations from time to time. I use that word escalation to distinguish from just a flare of the disease. These escalations over time, typically following major stressors, either major physical stressors like trauma or surgery or puberty, pregnancy, delivery. Not to say these patients can't get pregnant, can't have kids, but you can't deny that pregnancy and delivery are major physical stressors. Major psychological stressors too, sometimes major infections, occasionally even vaccinations. I am not anti-vax. I'm very, very much pro-vax, but you can't deny that vaccines are designed to mimic major infections. And so they can induce major physical stress in the body. So all these major physical stressors and sometimes major psychological or emotional stressors sometimes can induce one of these escalations. But in my experience, the better controlled the mast cell disease is at the time the patient is hit by the stressor, the less likely the stressor is to spark an escalation. And even if an escalation is sparked, the less severe it tends to be. So anyway, this is the natural lifetime course of the disease. So what are the goals in treating? Yeah, you ought to understand what the goals are in treating any disease before you set out to treat it. The inappropriate goals are that you can't cure it. It's far too biologically complex to expect anybody's going to be able to cure this anytime soon. I mean, fundamentally, we know from the research most of these people have somatic mutations, acquired mutations in the mast cells that are driving the misbehavior of the mast cell. So it's obviously going to require genetic engineering to some extent to truly cure this in most people. And yeah, we're just at the infancy of all that. Come back in, I don't know, a century or two, maybe somebody will start paying attention to genetic engineering and mast cell disease, but it's going to be a long time before we can cure it. It's also far too complex a disease for it to be rational to expect the disease can be controlled perfectly. There's no way these patients are going to get to feel perfect. And frankly, many of them don't really have the foggiest idea what feeling perfect is like because they've really been sick from the disease to one extent or another pretty much their entire lives. You can't even control such complexity well or satisfactorily for 100% of the time. There's always going to be some ups and downs with this for the rest of their lives. So the goal is to get to the point where you can feel significantly better compared to the pre-treatment baseline the majority of the time. And in my experience, most people who have this disease do sooner or later piece together some cocktail that really does get them to that goal. But I'll be the first to acknowledge that at least at present, this is an entirely subjective goal. There are no tests that can reveal when the patient has hit the goal. Don't even go thinking that repeating the diagnostic tests are going to help you. Because again, think about this. We're testing in the diagnostic testing only about 10 or so of the more than 1,200 mediators these cells put out. So clearly the symptoms in these patients, which of course are all coming from inappropriate expression of the mediators, the symptoms are coming about from inappropriate expression of media. Well, the symptoms, almost all of the symptoms are probably coming about from inappropriate expression of mediators other than the ones we're measuring. Clearly, what we're measuring is a terribly poor surrogate for the totality of the signaling chaos out there. So remeasuring, a histamine level or a leukotriene E4 level probably is not going to tell you much about whether the patient is actually feeling better. So right now, it's admittedly subjective, and when the patient feels well enough, whatever that means to the patient, and I tell them explicitly they should never let anybody else ever tell them that they're feeling well enough. Only they know how they feel, and They're the only one who's competent to judge whether they're feeling well enough. And when they get to the point of feeling well enough, not perfect, but well enough, whatever that means to them, for enough of the time, not all the time, there's always going to be some ups and downs, but enough of the time, whatever that means to them, that at that point it's just no longer worth it to them to keep trying yet more mast cell targeted treatments in the hope of achieving an even better baseline degree of control over the disease. Then at that point, congratulations, you're at the goal, and you likely will continue cruising for a long time to come at that point with that degree of control over that disease, using that particular cocktail of treatments pieced together by that point. And you'll probably just keep cruising for long periods of time to come, with the caveat that, you know, anybody in life is subject from time to time to these major stressors, usually coming out of the blue, that have potential to spark an escalation in the disease. But these are the goals, and I explain this very explicitly to these patients. So as they go down what's often a long and complex treatment path, they have appropriate expectations. So treating MCAS, the mantra, at least the mantra I've come to adopt out of experience with this. And if other people have different perspectives based on alternative bases of experience, then I'd be interested in hearing those ideas too. But what I've come to experience with this has led me to this mantra. The principles I teach all of my patients in for the principles for successfully managing this insanely biologically complex disease across the course of a lifetime are patience. Both the patient and the treating doctor have got to practice enormous amounts of patience, persistence, and a very methodical approach, trying to make just one change in the regimen around any given point in time to the extent possible, for the simple reason the moment is either the patient or the doc starts making two or more changes around the same time, and then the patient gets either better or worse, you're gonna have no idea which change is making the patient better or worse. It's quite often a holy mess, and sorting it out at that point. I do understand everybody in life from time to time faces urgencies and emergencies where the patient and the doc have no choice but to make multiple changes around the same time. And, you know, that's life and you deal with it. But as much as is possible, which of course is the great majority of the time, both the patient and the doc have got to have the patience to make one change at a time. And quite often it's actually the doctor who has the greater problem with this. He's busy, doesn't have much time to spend with the patient, and so he may just scribble out a whole bunch of prescriptions at one time and toss them at the patient and say, look, go try, go start all of this. And if you get better, then, you know, then we'll try to figure out what's actually working and what's not. And I've learned the hard way, boy, is that the wrong way to do this. So try as best you can, one change at a time. These are guidelines. Every once in a while, you see strange situations where you gotta deviate, make exceptions. But, you know, this is the mantra that served me well with the great majority of my patients over the last 16 years. I've been falling down this mast cell rabbit hole. Right, so those are the principles. Again, patience, persistence, and a methodical approach. So now let's talk about the steps in managing this ridiculously complex disease. Step one, as best as I've been able to identify so far, it'll probably change, you know, a century or two from now, when with genetic engineering we can really cure this disease. That'll be step one. But until then, identify the patient's triggers as precisely as possible, then do your best to avoid them, for the simple reason that it's actually kind of hard for any drug to gain good, sustained control over dysfunctional mast cells as long as the patient is simultaneously ingesting or otherwise exposing himself to a trigger. Now, over time, as you come to gain better control over the disease, these patients may well manage to regain some measure of tolerance to things which previously had become intolerable, but that's over time. So to begin with, Identify the triggers as precisely as you can, do your best to avoid them. In some of these patients, it's certain substances, foods, drinks, environmental exposures, pollens, grasses, mold antigens, sometimes known as mycotoxins, various animal danders, various chemicals, be they natural or artificial, be they solid or liquid or aerosolized, like odors or fragrances. So for some people, it's certain substances. For some people, it's various activities or various extents of various activities. For some people, it's various stressors, either psychological or physical. And for many people, it's actually certain physical forces like heat exposure, cold exposure. For some people, it doesn't even matter whether it's heat or cold, but just rather any change, either up or down in the temperature, in the tissues where the dysfunctional mast cells are, that can be a trigger. Had a patient just yesterday who clearly was getting triggered whenever cold IV fluid, IV saline, was infused into her. Boom, instant triggering from the cold. And I mean, it makes all the sense in the world when you think the mast cells can be triggered by cold and you think of the anatomy of this. I mean, where are the mast cells in the body? Yeah, they're everywhere, but in most tissues, pretty sparsely distributed. They're dominantly found at the environmental interfaces. So the integument, the respiratory tract, GI and GU tracts, so the environmental interfaces, and directly abutting all vessels and all neurons. So if you put an IV in, and right there in the vein wall, proximate to the entry site of the IV, you got some dysfunctional mast cells that ordinarily are sitting at body temperature, and then you go suddenly infusing cold fluid. That's going to be a thermal shock to those mast cells. Normal mast cells won't be bothered by that, but some dysfunctional mast cells can be triggered by a temperature change. Anyway, so there can be heat or cold or temperature changes, pressure changes, sometimes requiring, traumatic degrees of pressure. But in some patients, changes in pressure as subtle as just barometric air pressure changes with an approaching storm, or when the plane goes up or the plane goes down. Some of these patients actually learn to med up when they board the plane, so the meds are at peak level in the blood by the time the plane actually gets around to taking off. And likewise, if the flight's long enough and the meds have worn off, then they met up again about half an hour before the flight's expected to begin descending. For some people, it's certain low wavelengths, bass audio tones, vibrational frequencies. For some people, it's certain high wavelengths, certain high audio frequencies, or even wavelengths way higher than audio. Radio frequencies, ultraviolet, like you get from the sun. And I don't know if y'all are aware of this or not, but it turns out you get a good dosing of ultraviolet from all fluorescent lighting. So there's some patients, not many, but some, who walk into a building or an office that's fluorescently lit, and within a few minutes they're having a flare of some of their symptoms. So all these things have got to be considered. The good news is that almost all identifiable triggers actually are manageable. And yes, sometimes it takes a good bit of creativity to figure out how to effectively manage a given trigger, but almost every trigger is manageable. That's not such the hard part. The hardest part is figuring out what the triggers are. Most of this work is going to have to be done by the patient and those closest to the patient. And sometimes history taken by the physician can help identify this, but most of this is going to have to be done by the patients and those surrounding them. And quite often it's keeping a diary. I teach all my patients, you really ought to be keeping a diary, so that anytime you have a flaring of any of your symptoms, and as soon as you can put two brain cells back together again, you put a short entry in your diary, the date, the time, the symptoms, where you had been at the time, what you'd been doing at the time, what you most recently ingested, whether it was food or medicine or anything else. Any noticeable odors, other major sensory stimuli in the area at the time, what the weather was like in the area at the time, any significant stressors, either physical or psychological, that were being suffered at the time. And so it's usually going to be the case. Most flares are not going to be able to figure out exactly what the trigger was, but if you keep a record of all this, quite often over time, the patterns start to become apparent. And I also teach all my patients that it's very common for mast cell patients to adversely react to medication products. And please be careful not to distinguish drugs from supplements. They're all foreign substances to the human body. And it's just unfortunate, at least here in the US, that the political system is so idiotic and stupid that these drugs that are that the manufacturers are able to get classified as supplements, they're under no obligation whatsoever to reveal what the ingredients in those products are. And even if they do publish an ingredient list, there's nothing binding them to making it an accurate or a complete ingredient list. In fact, there are plenty of studies out there now showing that the ingredient lists on a great many supplements out there, actually the majority of supplements actually are not correct or complete. So fortunately, the drugs are much more heavily regulated. Doesn't mean they can't from time to time have contaminating excipients in them, but you have a much better understanding of what's in the drug products and the supplement products. But fundamentally, they're all really drugs. But whenever a mast cell patient is newly trying a medication product, and keep in mind this includes the scenario that when they go to get a refill on their product, but the pharmacist switches them from one formulation to another, it really is a whole new product. Yeah, the drug's the same, but the excipient package, all those inactive ingredients, I hate that term, inactive ingredients. Yeah, they're inactive in most people, but in a mast cell patient, any one of them could be terribly activating, unless, of course, it's already a natural compound in human biology. But any one of those excipients could be a trigger. And in fact, in my experience, when a mast cell patient is reacting to some medication product being newly tried, so within the first few doses, they start having an adverse reaction, it's far more likely it's a matter of excipient-driven reactivity rather than drug-driven reactivity. So it's a huge opportunity. I mean, nobody likes to have adverse reactions, but in a mast cell patient, when they have an adverse reaction, it's also a huge opportunity to potentially identify more of the patient's triggers. So you have to explicitly teach these patients and repeatedly review this with them to leverage these incidents to try to identify the triggers in the product. And then once they've identified some particular excipient that really is a trigger, you got to go looking at the full ingredient list for everything else they're taking, because these patients can easily go from looking and feeling the picture of health to looking and feeling like death warmed over within minutes, even seconds of ingestion of or exposure to even a trace amount of whatever whatever's a trigger for them. So there's no getting around step one, no shortcuts, no bypasses, no short circuits. Figure out the triggers as precisely as you can, do your best to avoid them. And if you look at the ingredient list for a troublesome product and you say, oh, I think it's, red dye number 40, then you work with a pharmacist, you find another formulation, same drug, same dose, just with a different formulation that does not contain red dye number 40 in the mix, regardless of whether it's another commercially available formulation or a compounded formulation. But the patient tries a new formulation. If they have a better experience with that product, you just proved it's not the drug that's the problem. It's the excipient. I could go on talking about more angles on this for a long time, but in the interest of time, we'll go on here. Sometimes spreadsheets, medication products across the top and ingredients down the side, and you put X's all over the place wherever a given ingredient intersects with a given medication product. You do this not only for the troublesome products, you do it also for the well-tolerated products, because by definition, any of the excipients in the well-tolerated products are not triggers. So if any of those excipients also show up in the ingredient list for some other product that is troublesome, then those particular excipients are not the troublemakers. You're looking for what's in the troublesome products that's not in the well-tolerated products. I've had some of these patients go back home after getting this initial lecture from me, and they put together one of these spreadsheets and they say, oh my God, it just leaps off the screen at me. Every product I've ever taken, it's got, I don't know, make up an example here. Titanium dioxide has given me a migraine headache, and every product I've ever taken that does not have titanium dioxide has not given me a migraine headache. And then I looked at the ingredient list of my current medications, and oh my God, half of them have got titanium dioxide in them. And so those patients, they don't go changing their drugs or the doses. They just change the formulations to scrub the titanium dioxide out. And then they often write me back a short while later and said, oh my God, I'm like 75% better. Not only my migraines, but many of my other symptoms, just for having scrubbed the titanium dioxide out of there. And those scenarios really give you a whole new respect for not only the potency of these mediators that are getting released in such tiny amounts from such a tiny number of dysfunctional mast cells that this can cause such remarkable symptoms, but it also gives you respect for how vigorously these dysfunctional mast cells can react in response to trace amounts of some of these triggers. Resources to help the patient investigate the ingredient list. Certainly the patient's pharmacist ought to be a good resource, and if the patient's pharmacist is not willing to try to help the patient with this, time to get a new pharmacist. There's also this subclass of pharmacologists, usually only found at academic centers, that offer a type of consulting service called medication therapy management services. And these are exactly the pharmacologists who do exactly this sort of work in reviewing the products, the ingredient list, trying to help the patients ferret out which ingredients are the triggers, and then help them track down alternative formulations that would make more sense to try. So some of these patients not only consult the doctor, they also consult an MTM pharmacologist to try to help them figure this out. There are some databases out there, some private, some public, for helping patients track down ingredient lists. And so here are some links to some of these resources in some countries. Fair warning about the Daily Med resource. It has recently become recognized that there are an awful lot of medication product entries in Daily Med where the listed ingredient list actually is not complete. And what's in Daily Med does not actually agree with what's actually printed in the product insert. There are software issues at the root of that actually are the fault of the manufacturers, not the FDA or the National Library of Medicine. But getting all that fixed is going to be a very challenging issue. I doubt it will ever happen. So just be aware there are, constraints in the quality of the information in at least one of these databases, much as you could say about the quality of information in just about any database. So, follow your gut intuition. If your gut intuition tells you there's something in this product that is troublesome, then accept that and deal with it. Find another formulation of the drug to try. Explicitly acknowledge to the patient that trigger identification, let alone avoidance, is hard. Even once you identify the triggers, accidental exposures can occur. This is why, knowledge is power. The better the patients understand what their triggers are and where these triggers can be encountered, the better prepared they are. For example, some of these patients, not many, but some are triggered by salicylates, like you find in aspirin and at the core of anything that tastes or smells minty. But did you know that salicylate is also at the core of aloe vera? And so some of these patients are going to react to anything containing aloe. Salicylates also are very commonly used in personal hygiene products and household cleaning products. So some of these patients, once they figure out they're a salicylate reactor, they just have to scrub the salicylate out of their regimen, and then they're fairly acutely doing significantly better. The patient should expect to not be able to pinpoint the trigger of a flare far more often than having success with these efforts. But if they don't even try, then the outcome's a foregone conclusion, because they will continue exposing themselves unknowingly to their triggers. And they will continue having flares of various symptoms, no matter what drugs they're taking to try to control the mast cells. So that's step one. Identify triggers best you can, do your best to avoid them. It's going to be, I tell all these patients, this is going to be step one, at least with respect to their health, not only now, but for the rest of their lives. I don't even know why I use the word step. I mean, if you think about it, the word step kind of implies they're going to be done with it at some point. But in truth, a mast cell patient is never done with step one. It's much more like it's a foundation, and everything else the patient is going to be doing for the rest of her life to try to gain and maintain better control over the disease is going to be something that's going to be built on top of a foundation of understanding what their triggers are. And I think what happens anytime you try to go building anything, either literally or figuratively, on top of a weak foundation. And most of these patients, as you might imagine, have a pretty weak foundation when they're just starting with this. Step two in managing this disease, best as I've been able to identify over the years, is to identify the antihistamine regimen, combination H1 receptor blocker and H2 receptor blocker, which is optimal for the individual patient. These are competitive blockers of histamine, keeping histamine from engaging with H1 receptors on some cells, H2 receptors on other cells. And believe it or not, you got both H1 and H2 receptors on a number of types of cells too, including not only all neurons, but also all mast cells. That's the principal reason we want all these patients to be on both H1 and H2 blockers on a round-the-clock basis. So we start with the antihistamines because the fact is most of these patients do find significant improvement in at least some of their symptoms with some combination of H1 and H2 blocker, and these drugs are cheap and they're pretty long-term safe. The one caveat being that the H2 blockers obviously reduce gastric acid production somewhat, and in some patients that can reduce gut absorption of certain acid-sensitive micronutrients enough over time to eventually develop one sort or another of a micronutrient deficiency. So sometimes it pays to keep an eye on these micronutrient levels every year or two, just check levels and make sure you're not running into a deficiency that might require you to back off on either back off on the H2 blocking, or another approach would be to just supplement the H2 blocker with additional acid supplementation, betaine hydrochloride, for example, just to get some extra acid in there to help with micronutrient absorption. Anyway, the patients likely are going to be on these antihistamine regimens for decades to come. And many patients ask me, look, I tried one or two of the H1s, the H2s. I got a lot of improvement. Why even bother trying the others? Well, until you try the others, you're going to have no idea what they can and cannot do for you. And if some of these patients come back from these systematic trials of the different H1s and H2s, and they tell me, I mean, yes, some of them tell me that their best H1 is serving them only modestly better than their second best, but so many of these people tell me their best H1 or best H2 serves them starkly better than even their second best. So if they're going to be living for decades to come, why do you want to do that with a suboptimal regimen? I mean, it takes some time to go through these trials on a systematic basis, maybe a few months, but if they're going to live for another few decades, they've got the time. So invest the time wisely, figure out their optimal antihistamine regimen. So I have them typically start just going through rotations of the different non-sedating H1 blockers. It's a chronically fatiguing disease in most people who have it. So why would a chronically fatigued person want to be regularly taking a sedating medication? There are some roles to be played from time to time in the management of this disease by the sedating H1 blockers, like diphenhydramine for a rescue of a flare of the disease. But by and large, we tend to start with the non-sedating H1 blockers. So I tell them to pick one of them. There are 5 on the US market, 4 over the counter, and 1 prescription. And our friendly neighbors up north have another 5, and it's pretty easy for most Americans to access supplies of those drugs. Just have your doctor send a prescription to whatever Canadian mail order pharmacy the patient chooses to deal with, and they'll send you a supply. So altogether, about 10 of these non-sedating H1 blockers that are pretty easy to access. Actually, up on the Canadian market, rupatadine is a particularly interesting one because it addresses not only H1 receptors, but also some other receptors on the surface of the mast cell that have relevance in mast cell disease. And so if you're going to try anything on the Canadian market, rupatadine is probably the most interesting one to try. The Canadians, not the Canadians, the Europeans, where this drug is also widely available, they love rupatadine. Not only settles mast cell activation, often settles eosinophil activation too. Anyway, so there are 10 of these H1 blockers. So you pick one of them. I don't care which one. There's no right order. There's no wrong order. I don't care whether it's name brand or generic. I don't care whether it's gel cap or capsule or tablet or liquid or compounded. None of that matters. The one caveat is that all of these non-sedating H1 blockers and all the H2 blockers are extraordinarily well-tolerated drugs, so at routine doses. So if the patient starts having any adverse reaction shortly into starting a trial of the first formulation that the patient or the pharmacist has randomly grabbed off the shelf for the patient to try of any of these drugs, it's almost certain to be not the drug, but rather some excipient. It's a huge learning opportunity, and no mast cell patient should ever squander any learning opportunities this disease presents them. So if they're having a problem with the product, yeah, stop taking the product, but work with the pharmacist, look at the ingredient list, try at least 1 or 2 other formulations of the same drug, same dose, just with a different excipient package. But setting aside the possibility of an adverse reaction, assuming that the patient will tolerate all these products okay, you pick one of the H1s, standard over-the-counter dose for that drug. It's obviously a different dose for each different drug, twice a day, by which I mean about every 12 hours. I'm not talking breakfast and lunch or bedtime and breakfast, talking about every 12 hours, and you got to run with it for a couple of weeks. Again, presuming the patient is tolerating it okay. If they're not tolerating it, stop it, work with the pharmacist, try a different formulation. But if they're tolerating it okay, got to run a couple of weeks because the disease is always doing this. And if you try a given drug for just 2 or 3 days, you're going to have no idea what that drug can do for controlling that disease. And just as importantly, what that drug cannot do for controlling that disease. You need a couple of weeks, and then you rotate to the next H1 blocker. Standard over-the-counter dose, twice a day, couple of weeks, and then the next, and so on and so forth. Many patients actually keep diaries, so every night at bedtime, they put a short entry in their diary, the highs and lows of the day. Some people even keep score. Today, I was 3 out of 10 of my worst, 7 out of 10 of my best. Some people even keep different scores for different symptoms, and they track it all on a spreadsheet. These patients usually are smart enough to know how they best keep track of things. The point is, you don't want to let them get to the end of the H1 trials, and then at that point, they can no longer remember. Remember, a lot of them are suffering cognitive dysfunction, including memory issues. You don't want to get to the end of the H1 trials, and then at that point, they can no longer remember the details of how they did with the first 1 or 2 or 3 of them, because if they've forgotten those details, they might have to go back and repeat those trials. But in this fashion, most patients get to the end of the H1 trials, and it's pretty clear to them which one is serving them better than the others. Got to be realistic here that it's very complex disease. No way is something as simple as the optimal H1 blocker going to fix all their problems. Boy, are those rare patients. But what they're looking for is which H1 is going to serve them better than the others. And most of these patients can pretty easily identify that. So once they got their best H1, great, switch to it, start using it regularly, twice a day. Some patients at that point try a couple other tweaks. They try stepping it up to 3 times a day, or they try double dosing. But if a couple of weeks with those experiments doesn't really make a difference, then they back off to just entry-level dosing twice a day for the long haul. So once they've got their optimal H1 blocker, optimal dose and frequency, then you pile on top of that similar rotating trials of the H2 blockers. Pick one of them, standard dose, 2 or 3 times a day to pair it up with the H1 blocker, and you run a couple of weeks, and then you rotate to the next and the next and the next. There are only 4 of them, and by the time they finish with that, pretty obvious which one of those is serving them better than the other 3, so they switch to the best H2, start using it long term together with their best H1, and at that point, congratulations, they have completed step 2. They have identified their optimal antihistamine regimen, which is a really valuable piece of information for a mast cell patient to have for the rest of his or her life. And this slide here is just saying in more words what I think I just said. So yep, same thing. Just, once you've figured out your optimal H1, just pile the H2 trials on top, and you want to try to make one change at a time, best you can. Just a reminder about that. One other note about the antihistamine trials, there are occasional MCAS patients who have obvious substantial issues in the central nervous system, whether you superficially classify them as neurologic issues, cognitive issues, psychiatric issues, dysautonomic issues. And in those patients, you got to keep in mind that the non-sedating H1 blockers, well, they're non-sedating because they have a chemistry to them that prevents them from transiting from the circulation through the blood-brain barrier that wraps around all the blood vessels up in the head. So those H1 blockers cannot get to the H1 receptors on either the neurons up here or on the mast cells up here that are abutting all the neurons. So all the histamine that's floating around in these patients, the non-sedating H1 blockers may be doing a good job blocking the engagement of that histamine with the mast cell, with the H1 receptors on the mast cells everywhere else in the body. But all that histamine floating around in these patients is still getting into the H1 receptors on the mast cells up here and is further activating those mast cells in the fashions that happen when histamine engages with an H1 receptor on a mast cell. So in some of these patients who are having a lot of these central neuronal issues, which are coming about because of the inappropriate, coming about dominantly, not exclusively, but dominantly because of the inappropriate release of inflammatory mediators from the dysfunctional mast cells up here that are directly abutting the neurons. So at that point, it's just a matter of which mediators are hitting on which neurons as to whether you'll get any particular neurologic or cognitive or psychiatric or dysautonomic effects. So in those patients, having these central neuronal issues may be either replacing the non-sedating H1 blocker with a sedating H1 blocker, or possibly adding a sedating H1 blocker to a non-sedating H1 blocker, although I hate making regimens more complex than they need to be. This can be a very reasonable approach in these patients. Don't go thinking that every time you give any dose of a sedating H1 blocker to a patient, you're going to sedate them. If you give enough of a sedating H1 blocker to anybody, yes, you will sedate them because the drug docks with the H1 receptor on the neuron. You ratchet down neuronal activation. Eventually, that sedates people. But oftentimes, we can find more moderate doses of these so-called sedating H1 blockers these CNS penetrating H1 blockers that don't hit on the neurons enough to cause sedation, but actually hit on the H1 receptors on the mast cells enough to gain enough additional control over the inappropriate activation of the mast cells up here that you wind up with a wide range of downstream improvements. In fact, many patients, I've seen this happen many times, these chronically fatigued patients, they take a sedating H1 blocker and they actually wake up for the first time in years or decades. And their primary physicians, of course, just think it's placebo effect. And they don't understand that the fatigue was coming about in the first place because of the inappropriate activation of the mast cells up here hitting on the neurons in a fashion that was driving the fatigue. And if you can simmer down the mast cells up here, then the neurons start functioning more normally. By the way, the last point here, all H2 blockers penetrate into the central nervous system easily. Actually saw a patient just yesterday who had figured out that famotidine alone did a fabulous job in settling down her episodes of anaphylaxis. And a whole range of other central neuronal issues. All right, so this is what I just said here about how sometimes the sedating H1 blockers don't sedate them, rather wake them up. This is a good point to just mention. So often you see in the charts of these patients, you see other doctors have written words like weird, curious, strange, odd, unusual. I've learned the hard way. Anytime you start seeing language like that in a patient's chart, boy, your MCAS radar better go on high alert. No, of course, those words don't prove a diagnosis of MCAS. There are a lot of strange diseases out there, but nevertheless, you start seeing things happening in patients that the doctors just can't easily explain. These are exactly the sorts of patients that you need to start thinking about whether MCAS might be at the root of their problems. Everything that happens in these patients makes no sense at all until you learn the biology and anatomy of this, pretty much like any other disease. It's just that none of us are yet taught any of this anatomy or biology. Nobody's taught where the mast cells are in the body. And as far as the biology, what you're taught, there are two mediators, histamine and tryptase, that these cells produce. You're taught they have one receptor, the IgE receptor, which is how they get wrapped up in allergy. Well, the reality of it is they put out more than 1,200 mediators. They express more than 300 receptors. I mean, the range of troubles these cells can get a person into if they are misbehaving in one fashion or another. There's just no end to it, but it all starts to make sense once you come to understand the biology and the anatomy of this. So again, just a few other tips regarding step 2. Some patients find slightly higher doses to be more effective. Sometimes it's slightly higher frequencies. These drugs are very well tolerated, so if they have troubles with them, think about excipient issues, not drug issues. And finally, and by the way, let me just mention again, this lecture, like the last one, probably going to run a little bit long. So I'm glad we're doing this on a Saturday. And anybody who has to leave after an hour, I'm sorry, but hopefully the organization will make the slides available to you at a later point. But steps 3 through N are to try, and then try some more. These many other drugs which have already been found helpful in various mast cell patients. It's still appropriate with each failure to reconsider the differential diagnosis, but if you can't identify a better diagnosis and you prove an MCAS, then MCAS remains the right diagnosis. And you just have to accept the clinical and therapeutic heterogeneity of the disease and try another MCAS targeted treatment. There's no way at present to predict, honest to God, I'm not exaggerating here, not a single method yet to reliably predict which medications are most likely going to help which patients. For example, just because you have a high histamine level, don't go thinking that antihistamines necessarily will be huge game changers. Just because they have a high leukotriene E4 level doesn't necessarily mean that, Montelukast is going to be a game changer, because again, most of their symptoms are coming not from the mediators you're finding elevated in this very limited testing. Their symptoms are coming about almost always because of inappropriate expression of mediators other than what you're testing. So no way at present to predict which medications are most likely going to help which patients, but most of these patients do eventually find some significantly helpful regimen. And the only way to lose at this game, so to speak, is to stop trying. So that's why patience and persistence are integral to success in this. And keep in mind too that the cost of any given drug bears no relationship to its likelihood for helping the individual patient. So there's really not much point in trying the expensive stuff until the patient has tried and failed the cheap stuff. Yeah, these are guidelines. Every once in a while, there are exceptions for various specific reasons in specific patients, but in general, I try to start cheap, for example, the antihistamines, and then we escalate from there as needed. So some examples of other things that make sense to try in these patients, given what we do so far understand about the biology of these cells. Well, these cells absolutely produce a range of prostaglandin mediators, so COX-1 and COX-2 inhibitors can be very helpful. And because most of the NSAIDs offer only reversible COX inhibition, then it's the irreversible COX inhibitor, aspirin, that usually works better for these NSAID responsive patients. You got to be a little careful with the dosing. Excessive dosing obviously going to create some risk for toxicity. But if you're careful with the dosing, then these patients tend to tolerate, a modest dosing of aspirin, indefinitely without troubles. And some patients have phenomenal responses to plain, simple, cheap aspirin. Interestingly, some of these patients just cannot tolerate any COX-1 inhibition at all. But if you give them a selective COX-2 blocker, then they do quite well with it. And that implies there's something about blocking COX-1 that actually further activates these cells. Hard to figure out the circuitry in that scenario. I don't understand it, and I haven't seen anybody figure it out yet, but nevertheless, it is a pattern I've seen in a few patients. Vitamin C is one of very few interventions we found so far that can actually inhibit mast cell production and release of histamine. So vitamin C, preferably in a slow release formulation, preferably twice a day, sometimes can be very helpful in these patients. Though be aware that with super physiologic dosing of vitamin C, that does increase risk of ratcheting up oxalate production. So consider checking oxalate levels before starting super physiologic vitamin C dosing. Vitamin D, plenty of vitamin D receptors on the surface of the mast cell. And we know that in a state of vitamin D deficiency, the mast cell actually ratchets up its production and release of various inflammatory mediators. And conversely, when you saturate all those mast cell surface vitamin D receptors with vitamin D molecules, the mast cell then ratchets down its production of various inflammatory mediators. So vitamin D deficiency, particularly when it's a moderate to severe deficiency, can be very important to address in these patients. I've seen a number of them with severe vitamin D deficiency. You just fix the vitamin D, and already you can see a wonderful settling of a wide array of their obviously mast cell driven symptoms. Now, to be clear, again, you already heard me say that mast cell disease has a number of mechanisms by which it can actually itself drive micronutrient deficiencies, acid inhibition, duodenal inflammation, inflammation in the terminal ileum. So sometimes it's a chicken and egg thing, but nevertheless, if they're deficient in vitamin D, you got to address that. The flavonoids, another whole class of medications which can inhibit mast cell mediator production and release. Quercetin often is helpful. Luteolin, not uncommonly, is helpful. Ketotifen sometimes can be a helpful drug. That's not a flavonoid, but it's just another drug that can be helpful. Here in the US, the only commercially available formulations of ketotifen are eye drops. And actually, this note at the bottom of the page about preservative-free single-use ampules, that actually is now out of date. The one company making that formulation, I learned just a short while ago, they've actually taken that formulation off the market now. It's a real shame because that product made a difference for a number of my patients. But there are no commercially available oral formulations of ketotifen in the US. Everywhere else in the world, it's readily available, sometimes even over the counter in cheap oral, commercially available oral formulations. Here in the US, the only way you're going to get it orally for systemic use is by compounding, but it's readily available from compounding pharmacies. So I started a low dose twice a day. You ratchet it up weekly as they tolerate it to either maximal efficacy or maximum dose in the 4 to 6 milligram, 2 to 3 time a day range. It only takes about a month. I told you most drugs that you try in this disease, it only takes about a month to figure out whether they're going to be significantly helpful for the individual patient's particular variant of this highly variable disease. And with the antihistamines, it's only a couple of weeks for each of those trials. If you get to the end of the trial and you're not seeing obvious significant improvement in at least some of the symptoms, then forget it. That drug is not the right molecular key for fitting into the particular molecular lock that is the individual patient's particular variant of this highly variable disease. So you ditch it and you move on and you try something else. Lipoxygenase inhibitors can be considered here. Hydroxyurea can help occasional mast cell patients, particularly those who have a whole lot of bone pain in them. Man, I try to stay away from steroids as much as possible. Yeah, if they're having a really severe, inflammatory, acute inflammatory reaction, nothing wrong with a short course of steroids, but everybody knows there's substantial chronic toxicities from them. So try to avoid getting your patients on chronic steroids as much as possible. Plenty of other drugs to be tried. Cromolyn often is a helpful drug, but it has a very short half-life, about 90 minutes in the human body. So it's got to be, typically has to be dosed 3 or 4 times a day. And it's a very poorly absorbed drug. So you drink it, yeah, it'll help settle down the mast cell activation in the mast cells in the most upper parts of the GI tract. Drug doesn't even last long enough to get to the lower end of the GI tract, but it doesn't get absorbed, doesn't going to circulate, not going to help settle down mast cells anywhere else in the body. That having been said, don't go thinking for a moment that cromolyn applied to one part of the body, orally, nasal, eye drop, nebulize into the lungs. Don't go thinking for a moment that just because you're applying cromolyn to one part of the body that you can't see improvements in other parts of the body. And the reason is that, yeah, when a mast cell in any part of the body releases its mediators, sure, there are going to be some local effects, but there's a whole range of mechanisms by which locally released mediators can go on either directly or indirectly to have profound and very distant effects. I've seen oral cromolyn completely fix severe mast cell driven bone marrow problems. I've seen oral cromolyn practically cure autism. I've seen nasal cromolyn dramatically improve autism. Seen eye drop cromolyn dramatically improve bone crushing fatigue. I have not yet figured out how to predict what impacts you might see from applying cromolyn to any one particular part of the body. But when you see oral cromolyn fixing a bone marrow problem, that tells you, since the drug doesn't get absorbed, doesn't circulate, it tells you there has to be something about the misbehavior of the mast cells, specifically in the upper part of the GI tract, that they're releasing mediators that are coming to either directly or indirectly drive the bone marrow problem. That's the only way to explain that. And don't go thinking for a moment that the manner in which mast cells in one part of the body are misbehaving, that's how all the dysfunctional mast cells everywhere else in the body are misbehaving too. We started learning decades ago that mast cells, both normal and abnormal, can operate in very different fashions in different parts of the body. Um, anyway, so chromolin's an option. The benzos are great options in many of these patients. They engage, I mean, everybody gets taught they address anxiety because they engage with inhibitory benzoreceptors on the neurons, and all that's true. But it happens to be that you got exactly the same receptors in all mast cells. So benzos often can be very helpful in simmering down mast cell activation. But you want, I mean, the disease is 24/7 active, so PRN benzos, that's not the way to do this. You want to use chronic round-the-clock benzos. Yes, everybody's afraid of addiction, and it's true if you give high doses of benzos on a regular basis, strong chance of addiction. But if you observe appropriate dosing constraints with these drugs, then honest to God, I've put hundreds out of my thousands altogether of mast cell patients I've seen over the years. I've put many hundreds on chronic low-dose benzos, and I have not seen a single case of addiction develop. They just, whatever low dose turns out to be their optimal dose, they just keep taking that year after year after year, and it just keeps delivering the same benefits. And fortunately, in the literature just recently, we're now starting to see new pieces in the literature saying all this worry about addiction has really, unfortunately, prevented a lot of doctors from using benzos in situations that could really help a lot of patients. So you got to learn how to properly dose these drugs, and if you observe the relevant dosing guidelines and constraints and thresholds, these drugs can be quite safe and very helpful. Cannabinoids can be helpful in this disease. Yes, there are cannabinoid receptors on the neurons, of course. That's how marijuana gives you the high. But turns out you got exactly the same receptors on the mast cells. And, THC is just going to give you a high. That's not going to help. But cannabidiol, CBD, is just purely an anti-inflammatory. And so that can be quite helpful in some of these patients. Very occasionally, we find that there's a little bit of THC added in, like a 10-to-1 or 20-to-1 ratio of CBD to THC. Occasional patients find that sort of a mixture even more helpful than pure CBD. But anyway, CBD can be an option. The endocannabinoids like palmitoyl, ethanolamide, sometimes are helpful anti-inflammatories in these patients. Low-dose naltrexone, not uncommonly, can be a helpful anti-inflammatory. These patients, you just obviously can't give it to anybody who's frequently or chronically using a narcotic. And ignore that comment about split BID. It's a rare patient who does better with that. This drug commonly causes troubles with sleep and dreams when it's taken in the late afternoon or evening. So I've learned to just give it morning only. Alpha lipoic acid and N-acetylcysteine occasionally can help some patients with peripheral neuropathies. Pentosan often can be helpful in interstitial cystitis, which the avant-garde urologists are increasingly learning is a mast cell, is an MCAS-driven issue in most of those patients. I really like what I've seen glycopyrrolate and sometimes other muscarinic receptor blockers do, especially for the mast cell patients who are having a lot of trouble with sweats. Omalizumab, the anti-IG monoclonal antibody, can be helpful in some of these patients. Not so helpful in those with very few food or environmental reactivities. More helpful in those with moderate levels of food or environmental reactivities. You got to be careful with this drug in the patients with severe ranges of reactivities. Those are the patients who are much more likely to have significant adverse reactions to this drug that sometimes can last for weeks or months on end. And like any monoclonal antibody, it's got a long half-life. So if you're going to start it in a patient with severe reactivities, you better start with very cautious dosing, likely to be subtherapeutic, but at least if they have a reaction, they'll only have a much more modest reaction than they would have if you gave them a full dose. So you start very cautiously, 10 or 20% of a normal dose, and then you work the dose up as they demonstrate they can tolerate it. That is, by the way, that drug is an injectable, typically once every 4 weeks, but some patients do better every 3 or 2 weeks. Other immunosuppressants occasionally useful in this disease, but by and large tend not to be too helpful. Lithium occasionally helps these depressed patients, particularly the bipolar affective disorder type 2 patients, which is increasingly apparently an MCAS-driven disease. Believe it or not, a couple of years ago, new literature started to come out showing that metformin, a drug whose mechanisms of action have long been elusive, metformin actually is now known to inhibit mast cell activation. So this can be helpful in some MCAS patients, and of course, it's also a pretty standard treatment in polycystic ovarian syndrome, yet another kind of subsidiary diagnosis that is seen in an awful lot of these patients. Remember, these mast cell mediators, they drive inflammatory effects, they drive allergic type effects, and they also are integrally involved in guiding growth and development in tissues all throughout the body. And we mentioned at the lecture last week that one of the most common types of abnormal tissue growth patterns you see in mast cell patients is cyst formation. So no surprise that MCAS is probably what's underlying many cases of PCOS. And so no surprise that if metformin is a mast cell inhibitor, that might be one mechanism by which it actually proves helpful in PCOS. Tyrosine kinase inhibitors can be considered in this disease. Most of them are frighteningly expensive. Imatinib came off patent a few years ago, and the pricing has plummeted on that. It can be helpful in some of these patients. Typically start at 100 milligrams a day, but 200 a day usually is the sweet spot. You usually don't have to get to dosing anywhere close to what's typically used in chronic myelogenous leukemia. No, it's not a chemotherapy drug. It's just a tyrosine kinase inhibitor. It's well tolerated in most mast cell patients. If you start a low dose of imatinib in them and they start having an adverse effect, you got to think excipient issues and try a different formulation. Some of these people actually figure out the troubling excipient is in the coating of the pill, and so they scrape the coating off, just take the core of the tablet, and then they tolerate it fine, and it helps them nicely. There's some other TKIs that have been occasionally used in a few mast cell patients. I've seen dasatinib very occasionally be helpful, sunitinib very occasionally be helpful. I've not seen any good effects from nilotinib or bosutinib or midostaurin. Masitinib is still investigational, going through a clinical trial right now in MCAS actually, but there are a lot of problems with that trial right now. And the latest one to hit the streets, avapritinib. There's just been no experience in MCAS, no significant experience. I think I've seen one patient take it so far, but it's too early to tell whether it's really having any efficacy. So for the most part, I just stick with imatinib when I'm going to test out the TKI waters in these patients. Got to keep in mind there are receptors for all the major sex hormones in these patients, sex hormones on the surfaces of the mast cells, estrogen receptors, progesterone receptors, testosterone receptors, and when progesterone or testosterone engages their receptors on the mast cell, that inhibits mast cell activation, but when estrogen comes to engage with an estrogen receptor on the surface of a mast cell, it further activates the mast cell. This is probably why many women with mast cell disease see worsening of the symptoms of the disease in concert with flares of estrogen in their menstrual cycles and during pregnancy. So sometimes the combination contraceptives, both estrogen and progesterone, sometimes can actually be problematic because you're giving them extra loads of estrogen that can further worsen the mast cell activation. So in some of those patients, it's just progesterone only contraceptives that can be more helpful. And you've also got options for blocking the estrogen receptors and blocking the synthesis of estrogen. These, to be fair, these options are rarely used in MCAS patients, but I've seen occasional patients who have been nicely helped by them. Um, the JAK-STAT pathway is right downstream from KIT, which is the dominant, it's a transmembrane tyrosine kinase that is the dominant regulatory element in the mast cell. Mutations in the mast cells in MCAS patients quite often are constitutively activating KIT. This drives a constitutive activation of the JAK-STAT pathway. So the JAK inhibitors, particularly the JAK1 inhibitors that are listed here, sometimes can be very helpful in these patients. SSRIs, they engage, we're all taught they engage with serotonin response elements, SREs, that are present on the surfaces of all neurons. That's all true, but you also got exactly the same SREs on all mast cells. So SSRIs, SNRIs, NDRIs can all be helpful because all the receptors being targeted by those drugs are also on the mast cells. Fluvoxamine may be the most interesting SSR to try in some of these patients because it seems to have more anti-inflammatory activity than like fluoxetine or sertraline and so on and so forth. IVIG, you can't find a more expensive way to treat a mast cell patient, but there are IgG receptors on the surfaces of these mast cells, and occasional patients see brief, 7 to 10 day modest improvements in a few symptoms with an infusion of IVIG, but this treatment also does nothing in a lot of patients, and in a hefty proportion of patients too, it actually triggers reactivity. Don't know whether it's the immunoglobulin itself or some excipient doing it, but you got to be cautious with this and understand that you're probably not going to get any big wins from IVIG. Yes, there are the exceptions out there, but it's so expensive. I tend to reserve this for trials much later rather than sooner in mast cell patients. Interferon, very rarely tried. It's commonly used in mastocytosis, but it's very difficult to tolerate. It's a very rare patient which we try this. mTOR inhibitors possibly have a role. That's another pathway that's active in mast cells. The GLP-1 agonists. There are GLP-1 like semaglutide, Ozempic, Wegovy, tirzepatide, like Mounjaro. Turning out there are GLP-1 receptors on the surfaces of all mast cells, and I'm starting to see some nice responses in a wide range of mast cell-driven symptoms in patients who are taking these drugs, even patients who are not diabetic or obese. So that's an interesting class of drugs we need to learn more about. Somatostatin occasionally helpful in these patients. So strategies, try to block the released mediators. So you try to inhibit mediator release. You try to block the mediators that have already been released with antihistamines. Try to use, occasional patients have diamine oxidase deficiencies. This is the enzyme in the GI tract that digests dietary histamine. Occasional patients have a deficiency of this. This can be tested for. And if they have a DAO deficiency, so more histamine coming into the diet is then getting into circulation, this can be a problem in some of these patients. So DAO supplements sometimes can be helpful. Leukotriene antagonists sometimes can be helpful in these patients. I found that the leukotriene receptor blockers like montelukast usually are much more helpful in these patients with twice daily dosing rather than once daily dosing. Be aware of the black box warnings with montelukast. Again, supplements, calcium and vitamin D. Basically, if there's demonstrated osteopenia or osteoporosis, which probably is being driven by the mast cell, yeah, again, basic biology here. The very first mediator ever discovered in the mast cells was heparin, and it turns out that heparin actually can drive osteopenia, osteoporosis. This is why we used to give all these women who were having repeated miscarriages, low dose heparin throughout the pregnancy, and we stopped doing that after a few years because they all got osteoporotic within a few months. So anyway, if they've developed osteopenia, osteoporosis, you got to deal with it with the standard treatments for that, which usually are pretty well tolerated, but sometimes they're not going to tolerate, say, a bisphosphonate, so you move on to, say, a monoclonal antibody like denosumab or rosasuzumab. Stimulants sometimes can be helpful for fatigue or ADD. I'm seeing an increasing number of patients who respond well to the tumor necrosis factor antagonists. Not surprising because mast cells do put out TNF among their 1,200 plus mediators, and mast cells actually also have receptors for TNF. So no surprise that TNF antagonists can be helpful in some of these patients, not just for the inflammatory bowel disease that they're, FDA approved and advertised for, but sometimes I see a wide range of other symptoms getting improved by these drugs. There are inhibitors of tryptase, kinase in development. There's now one H3 receptor blocker that's on the market, pitolisant for narcolepsy, that probably is being driven by MCAS, but it's a very expensive drug. So if you don't have an actual diagnosis of narcolepsy, you're probably not going to get access to it. Besides, there are very few H3 or H4 receptors on the mast cells, so nobody's going to be terribly surprised if you don't get a big bang out of an H3 receptor blocker. You might be able to fix narcolepsy, but don't be surprised if you can't fix anything else with those drugs. There are complementary treatments too, alternative and complementary, medicine treatments. You can try to inhibit so vitamin C and D, ALA, NAC, PEA, CBD are some of these treatments that can be tried. Many natural herbs and supplements, flavonoids, alkaloids, all of these herbs basically are anti-inflammatory in various mechanisms. Most of them are anti-inflammatory because they basically inhibit COX-2. Though some of the other pathways mentioned up here too are inhibited by some of these herbs. So nothing wrong with trying them, but again, if you get to the end of a month or so and you're not seeing an obvious significant response in at least some of the patient's symptoms, then forget it. It's not going to be the right molecular key for that patient's particular disease. So stop it, move on, try something else. Non-pharmacologic therapies can occasionally be helpful. There's certain behavioral retraining programs, generically called the limbic system retraining programs. Not a surprise that these help because, again, think of the anatomy here where the mast cells, the environmental interfaces, and directly abutting all vessels and all neurons. And there's some photomicrographs on this slide that illustrate just how closely, the mast cells and the neurons are directly abutting one another. Many places throughout the body, both peripherally and centrally. So if you manage to reprogram the reactivity patterns in the neurons, and this does take longer than just a month, typically 3 to 6 months of dedicated certain thought exercises that are prescribed by these different limbic system programs. But if you can reprogram the neurons, think about it. Anytime a mast cell and a neuron that are abutting one another, when the mast cell activates, kind of regardless whether it's normal activation or abnormal activation, the adjacent neuron is going to further activate, sending more signals all up and down the whole neural network that neuron's connected to. Conversely, when the neuron activates, whether sensations coming in from periphery or thoughts coming down from central, central, then the adjacent mast cell is going to activate, and all bets are off as to how dysfunctional the activation can be in a dysfunctional mast cell. Conversely, simmer down the mast cell, you'll help to simmer down the neurons, and you simmer down the neurons, you help to simmer down the mast cells. And it's that last aspect that likely underlies the effectiveness of some of these limbic system programs. I've seen remarkable reductions in food and environmental reactivities, more often reductions in food reactivities than environmental reactivities from from various and sundry of these limbic system programs in some mast cell patients. Rarely, if ever, cytotoxic chemotherapy. This is not a neoplastic disease. It's not a cancer. It's not mastocytosis. So, I mean, these are categories of drugs shown on the screen here that have been used in mastocytosis. And by and large, they usually fail to help in mastocytosis. It turns out to be pretty damned hard to kill a mast cell. But by and large, this is not a class of treatments to be considered in MCAS. And in theory, if you do an allogeneic stem cell transplant and you get rid of the mutated stem cells that are, of course, the progenitors of the mutated mast cells that are driving all the problems in these patients, then the patient ought to be cured. But this is allogeneic stem cell transplant is highly toxic, very expensive treatment. And so the only people you're going to do this in are the people who are the most severely afflicted. And those are precisely the people who are going to have the hardest time in getting through as toxic a procedure as allo stem cell treatment. So the only way anybody ought to be going through such a treatment is in the context of a very carefully designed, very carefully monitored clinical trial. And for all sorts of practical reasons, hard to see that anybody's ever going to get around to doing that. So I'm aware a lot of patients out there that are pursuing transplant therapy, stem cell transplant, usually almost always autologous stem cell transplant therapies of various sorts. I see very few successes with that, and actually quite a number of serious toxicities from that. So caveat emptor to any of your patients seeking stem cell transplant therapies for mast cell disease. The hard part in doing this is picking what to try next. You got so many options. What do I try next? And then kind of regardless of whether that helps or not, what do I try after that? And so on and so forth. And there just are no biomarkers yet available for predicting which interventions will be most likely to help which symptoms in which patients. So yeah, over the years, I've kind of picked up a few clues that sometimes influence my thinking about the sequencing of these treatments. If there are a lot of GI issues, I'll think about trying very expensive oral cromolyn a little bit sooner rather than later. If there are inflammatory issues, I'll think about an NSAID. If they've got elevated histamine, I'll think about vitamin C or DAO. If they're elevated leukotriene E4 levels or respiratory issues, I'll think about montelukast. The deep bone pain patients, I'll think sooner rather than later about hydroxyurea, low-dose hydroxyurea in those patients. Imatinib, a curious set of conditions I've found seem to augur a response to low-dose imatinib. The mildly polycythemic patients, the patients with Derkham's disease, which is an eponym for one of the inflammatory lipodystrophies where you palpate the skin and you feel all this lumpy bumpiness under the skin, and it's tender too. This is an inflammatory lipodystrophy called Derkham's disease. Sometimes, in fact, many times, it responds fabulously well to low-dose imatinib. I have seen utterly refractory, otherwise refractory, severe hypertriglyceridemia, I mean, to the point of making the patient's blood turn yellow, respond gorgeously to low-dose imatinib, obviously meaning that somehow it's the mast cell disease driving that hyperlipidemia. The specific mechanisms remain mysterious. Sometimes topical applications. Again, mast cells are involved in growth and development. That means healing. Poor healing is a common complaint in these patients. Sometimes systemic treatments help, but sometimes topical applications of these mast cell targeted drugs can help. Similarly, ophthalmic, nasal applications, all sorts of vaginal and genital tract issues in women with this disease. And sometimes systemic treatments help, but sometimes compounded vaginal suppositories or douches of diphenhydramine or loratadine, cetirizine, famotidine, cromolyn, ketotifen, benzos can be very helpful in some of these patients. The dyspareunia, they're not going to tell you they're having pain on intercourse, but it's a very common issue in these patients. And sometimes the marriages are, on the verge of falling apart or have fallen apart. But if you give, a topical mast cell targeted treatment, sometimes precoital, sometimes postcoital, the problem just goes away. And again, it's related to the anatomy here, where the mast cells, environmental interfaces, including the GU tract, they are sometimes activated by various physical forces, so friction or pressure. It can be a real trigger, and they release inflammatory mediators, and it hurts. Inflammation hurts. So sometimes it's just topical applications of these treatments that can be very helpful. Oral rinses for persistent, for like burning mouth syndrome, or just nonstop deterioration, one form or another, in the teeth. The teeth are just crumbling in these patients, and the dentist can't figure it out. So just treat the mast cells, and sometimes it gets remarkably better. I've been seeing some nice results just in the last few months with the GLP-1 agonists. Sometimes you have to treat other secondary issues. Ibabradine can be very helpful with the tachycardic palpitations in these patients, but that's not to say the other treatments for POTS can't also be helpful. Occasionally, proton pump inhibitors, NK1 inhibitors can be helpful in nausea, but other mast cell targeted drugs like cannabinoids and benzos can be very helpful with cyclic vomiting syndrome that's quite often rooted in mast cell disease. All sorts of drugs for depression can also help control mast cell disease. Please, however, don't go assume that new symptoms necessarily are due to the MCAS. Obviously, having one disease doesn't magically render you immune against developing any other disease. So, regardless of the likelihood that a symptom may ultimately stem from MCAS, you got to think about the other possibilities, do the appropriate diagnostic work. All right, enough said there. We're almost at the end here. Treat the secondary issues as they arrive. Here's a whole slide for you about what anaphylaxis is and what it isn't and how it should be treated. In the interest of time, I'll leave you folks to read that on the slide later. More about, exactly the correct approach to using epi. Many patients, they're given an EpiPen. They're never told how to use the EpiPen. So they really need to understand the right way to use it. So take a couple minutes to explain it to them. Perioperative management, planning is the key thing. Preoperative consultation with the anesthesiologist. Make sure they read any of the reviews in the literature about perioperative management of mast cell disease. So they're not going into the OR blind on this, and prepare a comfortable OR involvement. Some of these surgeons like to keep the operating room ridiculously cold, and yeah, that can be a trigger in some of these patients. So here are some approaches to perioperative management. And again, in the interest of time, I'll leave you to read this later. In general, it's the same approach as with flares of the disease. So perioperative, periprocedural management, very similar to management of flares. Some key nursing care issues, patient professional trust issues. Many times the patients aren't just that they're just not going to be listened to, and they're not making this stuff up. I mean, Munchausen's exists, psychosomatism exists, but they're rare diseases. So in general, if a patient is telling you about a symptom, and you don't understand it, just say, I'm sorry, I don't understand what's causing it, but don't dismiss it, don't mock it, or deny it, and see if you can engage somebody else to help you think more about what might be causing these mysterious symptoms in these patients. Just talking more about, I mean, some of these patients that go in the hospital, and the nursing staff and the janitorial staff, they're just, marching in all day long with perfumes and odors and cleaning solutions, and it just sets off these patients. So the whole nursing staff need to be aware of what's going on with these patients. More nursing care issues. I don't have time to go into this right now. Again, issues with the physical forces that can trigger these patients. What's next in treating these? Yes, we would love to develop predictive biomarkers that are prognostically and therapeutically predictive. I don't know, come back in, I don't know, 25, 50, 100 years, maybe we'll have started figuring that out. And honestly, I think that doing the genetic testing, figuring out the mutations that are in these dysfunctional mast cells, that's really going to be the best way to figure out not only why these patients are having the symptoms they're having, but figuring out which treatments are best going to help the individual patient. So that's it. And again, apologize for going longer than a typical lecture, but I did warn the organizers that diagnosis and treatment tend to run long. It's a complex disease. It is what it is. It's hard to apologize for that. So I'll be happy to shut up at this point, take any questions.
All right, so I get to be the one again handling question and answer, unless there's any of the panelists that first have a comment or question. No.
I'm going to drop in the chat what we talked about last week about the website you recommend, Dr. Afrin, the COPE library. It lists the mediators and the receptors, and it's in need of support. And you were right, it's only $9 a month if you pay annually. So I looked that up.
Yeah, I mean, yes, I understand there are some people who can't afford $9 a month, but honestly, if you've got this disease or you have any interest in this disease, you want to understand the biology of what's happening here. It is, I mean, no resource is perfect, but it is the single most comprehensive by far listing of mast cell mediators and receptors I have found anywhere, either in print or online. And it is rigorously written, very well researched, and referenced. And it's going to be a tragedy if it goes away because nobody wants to subscribe. So I hope it will help those who choose to access it while it is still accessible.
All right. So then,
And for those who don't know what we're talking about, the website is cells-talk.com. And you may have to put http://www.cells-talk.com in front of it, because if you just type in cells-talk.com, most modern browsers assume that it's HTTPS, the secure protocol. But this website, the developer of it developed so long ago, he didn't even bother developing a secure access to it. So it only has an HTTP interface. And if your browser assumes HTTPS, it's not going to connect to it. So you might have to put in explicitly http://www.cells-talk.com.
okay, so I'll go ahead and start going through the questions that we have on here. So the first one I'm going to bring up is Athena Hall. So you have a couple of questions in here. If you are ready, go ahead.
Thank you, Dr. Afrin, for never getting tired. My first question is, could you speak to the mechanism and connections between MCAS and centralized pain, and any thoughts that you have in your treatment approach with these patients, whether etiology makes a difference in your treatment approach, for example, biomechanical trauma versus infectious origin?
Oh, I don't doubt that etiology makes a difference, but for the great majority of these patients, I have yet to learn any reliable patterns as to which particular drugs or even which particular classes of drugs are most likely going to help any one of those patients. So, you know, you obviously want drugs that'll penetrate it. You prefer drugs that'll penetrate into the central nervous system, but fortunately, most of the drugs we use for this disease do accomplish that. Not all of them, but most of them do. You know, the pain, it's probably coming mostly from the mast cells that from various mediators being released by maybe peripheral mast cells, but more likely central mast cells. Then various inflammatory mediators hitting on pain-sensing neurons, whether peripheral or central, and it causes pain. So, I mean, if there are other treatments out there for addressing pain other than narcotics, obviously getting into a situation of narcotic addiction is not good, especially since narcotics pretty much all are mast cell activators. Some are much more egregious than others, but to one degree or another, virtually all opioids are triggers of mast cell activation. So we try to avoid those drugs as much as we can. Sometimes you don't have a choice. But if other manners of pain control are not working and you can define MCAS in that patient, then perfectly legitimate to try all sorts of different mast cell targeted treatment. I've seen patients who've had nonstop migraines for a quarter century and failed every classic migraine treatment imaginable. And then we figure out they've got MCAS, and it's sometimes, I kid you not, it's nothing but an H1 blocker or an H2 blocker or the combination of them that completely shuts down the migraines. And other drugs too that can help with pain. We talked about the deep bone pain and how low dose hydroxyurea can often be helpful with that. It's interesting because you know what's the other situation where you chronically use hydroxyurea? It's sickle cell anemia, and all those patients have bone pain. And we used to think it was the vaso-occlusion that was doing it, but actually research in the last dozen years has shown pretty clearly, nope, it's not the vaso-occlusion causing the bone pain in sickle cell. It's actually mast cell activation that's causing the bone pain in sickle cell. And if you know, we were all taught that hydroxyurea helps in sickle cell because it increases hemoglobin F, fetal hemoglobin production, and therefore you kind of automatically get a decrease in sickle hemoglobin production. But if you actually look at the data on that, the amount by which fetal hemoglobin production is increased by hydroxyurea is trivial. And it can't possibly account for why these sicklers are chronically taking hydroxyurea and seeing so much of a reduction in their crises and their bone pain. And you start to realize, and furthermore, one other key piece here, if you take care of enough sickle cell anemia patients, you realize that about 85% of those patients have pretty mild forms of the disease. Mild crises, very occasionally they take some modest pain drugs for 2 or 3 days, and that's it, the crisis is over. But then there's the other 15-20% of sickle cell patients, and keep in mind all sickle cell patients have exactly the same mutation in beta globin, but there's 15 to 20% of them that are horrifically severe patients. They're always having crises, always in the ER, always bone pain that takes 3 weeks to get over. And you say, what's different about if they've all got the same mutation? What's different about those 15 to 20%? And I published a paper about, I don't know, a dozen years ago that showed pretty much every single one of these bad sicklers, they've got MCAS. And you can actually transform a high resource consuming bad sickler into a low resource consuming good sickler just by getting the mast cell disease under better control. But when you start to put all these pieces together, you start to realize that maybe the reason hydroxyurea is working in sickle cell disease is because it's actually addressing MCAS in those patients. There's something about the drug that settles down the mast cells in a fashion where they're no longer releasing mediators that are driving bone pain. So I over the years, I picked up these few tiny hints about which drugs might make sense to try sooner rather than later in various MCAS patients for various symptoms, whether it's pain, as you asked about, or any other symptom. But I'll be the first to acknowledge this is far more trial and error. It's far more clinical art and experience on the part of the managing clinician, much more so than any amount of already published or established clinical science or research that's going to determine the particular sequence by which we go trying these many different drugs in the individual mast cell patient. And again, don't go thinking for a moment that the cost of the drug is going to augur response. Plenty of expensive things that are tried in these patients utterly fail. So unless I've got an awfully good reason for trying an expensive treatment sooner rather than later, then I tend to start with the cheap stuff and I escalate in expense as needed.
Thank you. The second part of the question kind of, I would say it overlaps in that there may be underlying issues and other connected issues to MCAS. So you spoke earlier about patients that are sensitive to barometric pressure changes. How would you distinguish whether you're treating the connection to MCAS versus, let's say, a biomechanical low-lying cerebellar tonsils issue that have descended downwards?
Well, it's basically a matter of looking at the symptoms, and when the patient goes for a car ride up into the mountains, and at the top of the mountain they're having all this flushing and urticaria and wheezing develop. I mean, not expecting that to be a cerebellar tonsillar issue, more likely a mast cell activation issue. Now, is it possible that by the descent of the tonsils that there's increased pressure in that local area, increased mechanical pressure in the local area, that the mast cells in that area are then getting further triggered by that? Yeah, that's possible. You can drive yourselves bananas trying to envision and imagine the molecular pathways by which various symptoms are getting driven in these patients. And I understand that overall, the best path to effective treatment is to figure out the molecular cause of the symptom, but many times it's just not apparent. You're just doing your best job you can guessing at this.
Thank you. I appreciate that and the complexity. That's an honest answer. Thank you.
You're welcome.
All right. So our next question that's coming up will be from, it's a person that was I guess I'm looking at the most uploaded ones. So the next one is going to be Nita Jane. So let me bring you up, Nita, just a second. All right, go ahead.
Hi, Dr. Afrin. Thanks so much again. I was wondering, have you seen any patients respond to other types of peptide therapies besides the GLP-1 agonists, like BPC-157 or KPV, vasoactive intestinal peptide, thymosin alpha-1, anything like that? And my other question was just, have you seen any patients who have high whole blood histamine but normal plasma histamine?
Yeah, actually, let me answer the second part first. There's no question. There are plenty of patients where you'll find histamine elevated in the plasma, but not the blood or the urine, or you'll find it elevated in the blood, but not the plasma or the urine. Maybe it'll be elevated in the 24-hour urine, but not the random urine. And there can be all sorts of reasons why you'll get these discrepancies. But keep in mind, you're not going to be getting falsely low. I'm sorry, correction. You're not going to be getting falsely high levels of any of these mediators. If anything, you're getting falsely low levels. And keep in mind too, these different tests are being run at different specialty labs all over the country. I think plasma histamine and random urinary histamine get measured often out in Salt Lake City. 24-hour urine histamine gets measured down in Burlington, North Carolina. Anyway, these different samples that you're getting from the patient, they're getting, packed up and shipped out to different specialty labs distantly located all over the country. These are highly thermolabile mediators, and if anybody in the whole chain of handling of these specimens does not do their job right, and they leave the specimen sitting unchilled for even just a few minutes. I mean, histamine's got a half-life at room temperature or higher of about a minute. So if some technician somewhere is leaving the specimen sitting out on a desktop unchilled for, a few minutes, you may not have lost all the histamine in the specimen, but you lost an awful lot of it. And so what may have been an elevated level to begin with when it came out of the patient's body may already be at a normal level within just a few minutes of mishandling. So I've learned over time not to let those discrepancies bother me. And I'm sorry, I've already forgotten the first part of the question. Try me again.
Yeah, no worries. I was just wondering if you had any benefit with other peptide therapies besides the
Oh,
GLP.
yeah. I've seen a number of my patients get placed on these therapies by their other doctors, typically functional or integrative medicine doctors. And I don't doubt those therapies are being tried because those doctors find those therapies actually do significantly help some patients. But honestly, I have not yet seen a single mast cell patient be helped by that BPC 157, or I forget the other one you mentioned, thymosin 1 alpha. Haven't seen any benefits yet. Maybe I'm just not seeing those drugs used in the right patients. I don't know.
Definitely makes sense. Have you seen any anecdotal reports on KPV? That seemed to be one that had more mast cell stabilizing properties than other peptides.
Yeah, actually, same thing, same answer for that peptide as
Okay.
well. We're 17 years into understanding this disease, into just starting to understand this disease even exists. So go easy on all of us. I mean, minimal research done so far. I think it'd be reasonable to go doing a study, a clinical trial on whether each of these peptides actually can make a difference. But probably going to be a long time until we come across the resources for doing these trials. I mean, they're far, the complexity of the biology is so great that the number of research questions that we'd like to address far exceeds the resource availability. So all in due time, I guess.
Definitely. Thank you. I appreciate it.
Right, so our next question comes from somebody who put in as an anonymous one. So I'll go ahead and read that one off. So right now it's the most upvoted. So for those of you who are attending, if you do see a question you would really like to see answered, please make sure you hit the little upvote button and they'll get popped up in the list faster. So the question is, can you talk about your perspective on mold exposure as a driver of ongoing MCAS issues, including in patients who have trialed dozens of MCAS drugs already? Testing for mold is not straightforward, both in patients and in building environments. As a result, there is a lot of exploitation of desperate patients who are convinced that mold exposure, even in the absence of definitive testing, is the root of their inflammatory cascades.
Yeah.
How to approach this issue of mold and the lack of appropriate testing and biomarkers.
Yeah, it's unfortunate the diagnostic testing in that area, let alone the development of treatment in that area is just so at such an embryonic stage at this point. And I will be the first to acknowledge that I did not pay nearly enough attention to mold and mycotoxin issues in my first many years of dealing with this, since really just the last, I don't know, 4 or 5 years, I've started increasingly paying attention to this. And there's just no question, at least based on my experience, that various mycotoxins can be horrific triggers for some of these patients. And oh my God, can this stuff be a cult? You can have the most pristine looking home, residence, work site you can imagine. But sometimes what's hidden behind the walls or in the HVAC systems, whatever, would curdle your blood if you could see it. And yes, the diagnostics are challenging. I have no expertise in this. The other two folks in my office, Dr. Dempsey and PA, Dr. Renard, they've got far more experience with the diagnostics and the therapeutics in this area. I don't even attempt to run these diagnostics or therapeutics. I'm fortunate to have a good resources. I just refer these issues. When I come to sense that this might be an issue in any of my patients, I refer my patients to Dr. Renard or Dr. Dempsey for the diagnostics and the therapeutics in these areas. But the key thing is to learn to suspect it might be present. And you're right, the patients who you've treated endlessly, you're not making any progress. And I've been increasingly seeing too, it's really the ones who are having these ridiculous extents of food reactivities. It makes me really wonder what sort of, at a molecular level, what sort of cross reactivity there may be between certain mold antigens, mycotoxins, versus various antigens in various foods. But these are the patients and patients who are living, it's easy if there's visible mold infestation, but anytime there's been water damage, water intrusion, floods, leaks, older structures in particular. I had a patient just yesterday who's been living for the last 7 years, during which time her illness has gotten a whole lot worse, living in this circa 1850 home. And when they bought it, they had a mold inspection done, and they only found a little bit of mold down in the basement. But they just sprayed for that, and then another mold test said, "Oh, everything's fine now." And she's horrifically ill, and I say, look, at a bare minimum, yes, you need to undergo testing, have the structure retested, and you have to undergo testing and all that. But at a bare minimum, move out for a week or two and see how you do. And if you already are doing significantly better, not perfect, but significantly better within just a few days of leaving a suspect environment, that tells you something is going on in that environment, whether it's mold or, I'll tell you another thing to watch out for. Sometimes these newer properties, brand new homes or renovated, remodeled homes, it's the new stuff that's been installed in them that is releasing various VOCs, volatile organic, various plastics, stains, paints, carpet stain protectors, yada, yada, yada. And some of this stuff is just humongously triggering. Some of these patients, they do a remodeling and they think they're going to be able to move back into the home right after the remodeling's done. And they find out, oh no, it's 3, 6, 12 months before the remodeling is done, before they can safely move back in to the
Well,
home.
along the lines of the cross-reactivity, it turns out that some of the molds, the hyphae, can end up cross-reacting to the toll-like 4 receptor, which is triggered during the spike from COVID hits that as well. And that amps up the immune system. And as you know, mast cells have toll-like 4 receptors also. So, I mean, it feels like there could be some cross-reactivity of incrementally increasing the inflammatory load. And then another way that might work in the house would be to just try a really good HEPA filter air cleaner in the bedroom. And is that going to make it? Does that make a difference? Because that could quiet down some of the air burden.
Yeah, some of these people, they know that, oh my God, are they triggered in their, upstairs bedroom? But if they move, if they sleep for even just a few nights, on the downstairs living room couch, they're already noticing themselves doing at least somewhat better. And so, yeah, okay, there's something in the upstairs bedroom that is, maybe it's in the insulation in the attic above that bedroom, and maybe all the wallboard comprising the ceiling is just heavily infested with, well, it may not have penetrated through to become a visible stain yet. But has anybody gone up in the attic and looked? So I know it's not cheap to do any of this. Professional inspections are expensive, but nevertheless, if you don't figure out what's going on, what's triggering their problems, then they're just going to keep suffering them. It's hard to figure out how to treat a problem when you haven't diagnosed it properly.
All right, so our next question is Annette Weaver. So I'll go ahead and bring you up, Annette, whenever you're ready. I think you're still muted, Annette.
Hello. Oh, hello. Hi. I was just wondering whether far infrared treatment could cause a flare of MCAS, but actually whether very small, low levels could potentially help.
I'm sorry, I think I missed a key word there. What could you repeat the question?
Far infrared light treatment. I was wondering whether that could cause a
I
flare.
have seen some of these patients undergo these treatments. Occasional patients have reported they're feeling somewhat better, wide variety of symptoms from these treatments. What the mechanism is, I have no idea, but I will tell you this bit of interesting biology. I actually saw not too long ago, I think just within the last year or so, a new paper on basic science in the mast cell arena, and turns out that the mast cells mast cells anywhere, including mast cells in the skin, actually can respond to light exposure at different wavelengths. Now, how that specifically ties into response to infrared therapy, who knows? But just understanding this new aspect of the biology of these cells, that, I mean, you'd think that the only cells that could respond to light, I mean, melanocytes and obviously the retinal cells, but son of a gun, mast cells can actually sense various light wavelengths.
Thank you.
All right, so our next question, one of our panelists is going to ask one of the anonymous questions there. Dr. Zola, whenever you're ready.
Hi. Yeah, so I was going to read one about excipients, which I had that question myself, is, are there any specific excipients Dr. Afrin has found to be repeat offender in terms of affecting patients, which might be worth eliminating? So at least in my experience, I think dyes that were mentioned before are pretty common. Milk proteins, lactose can be also seen in a lot of medications. What other ones do you usually watch out for, Dr. Afrin?
I have learned the hard way that any excipient that is not a natural chemical compound in the human body can be a trigger in at least some of these patients. Obviously, the chemical compounds that are natural in the human body, you know, if the product includes sodium chloride or water, no, that can't be the trigger. But pretty much anything else can be. It's actually pretty unusual to find patients who are reactive to all dyes. It's usually much more selective. Which particular dyes are the triggers in the individual patient? By the way, we were talking about salicylate reactivity. Were you aware that red dye number 40, which is a commonly used excipient, actually is a salicylate? So anyway, I'll tell you a particularly tricky one to investigate is cellulose. Many of these products have microcrystalline cellulose in them, but you know, everybody got taught in 5th grade biology that cellulose is a basic building block molecule in all plants on planet Earth, and that is true. But it turns out that every plant on planet Earth makes a slightly different form of cellulose, glycosylated differently, just subtle molecular alterations in the basic cellulose molecule in every different plant on planet Earth. And the mast cells can tell the difference. So I have seen no end of mast cell patients who turn out to be reactive to, oh, just as an example, cotton-based cellulose, but then they tolerate wood-based cellulose just fine. And I've seen other patients with the opposite reaction. I've seen patients who have been horrifically reactive to cedar-based cellulose, but they tolerate pine or birch-based cellulose just fine. I had a lady, where was she? Out in the Pacific Northwest, a health professional who we had gotten her mast cell disease diagnosed, treated under good control, and then all of a sudden she has a follow-up with me, and the wheels have fallen off the bus. She's right back to square one with all of her symptoms. And I've learned over time, anytime a patient tells me they had been doing well and now they're doing horrible again, something changed. And maybe it's food or environment, medication, whatever, something changed. And so I'm asking her, look, it's only been 6 months since you last saw me. You were doing fine last time. Now you're doing horrible. What changed? And I spent an hour on the video with her going through everything I could possibly think about. And she just could not identify anything that had changed, not even her medicines, refills month after month, exactly the same formulations. And then I get a message from her that, so we hang up and we really are unsure how to proceed. I'm telling you, something has changed. You just not need to keep thinking about it. And you know, I suggested some other meds you can try, but I said, look, you're probably not going to have a whole lot of success as long as you keep getting exposed to a trigger. So I then get an email from her, a message in her portal in my practice's EMR that evening, and she figured it out. Turns out that she hung up from the phone call, and she was just sitting there at her kitchen table, staring out through the window at her large backyard, just ruminating, trying to think about what else might have been the trigger, and just looking out through the big plate glass window over the big backyard, it suddenly smacked her right in the face. She was looking right at the problem. Turns out she had known since childhood. She was horrifically reactive to cedar. She was allergic, horribly reactive to cedar. So, but, you know, she made adjustments in her life, made sure to avoid cedar, and, you know, she got along okay. And then later on, the disease caused more problems. We had to diagnose and treat it. But anyway, she has this nice property in the Pacific Northwest. And she has across the rear property line, she's got another neighbor, and there's been a dispute for a long time over exactly where the property line is. And so she decided she was going to put up a fence along the surveyed property line but she didn't want to make it ugly like a fence. She was going to put a row of trees up there. So she calls in her landscaper, says, put a row of trees up there. And he asks her, well, what do you want? She said, I don't care. Just put some trees there. And it smacked her in the face after we got off the call. Oh my God, he planted cedar there, a whole row of cedar trees. And so she then called in the landscaper at great expense, ripped out all the cedar and put in something else, and boom, she was right back to the good state she was in before with her medication. So I'm not saying it's cellulose in the cedar that was doing that. It was obviously some cedar pollen that was, drifting into her home's air currents that were doing that. But this is the level of reactivity some of these patients can have. And those trees were, a good 200 yards behind her home. Sometimes what you got, you look at these excipient lists, they never tell you where the cellulose came from. The drug company does know where the cellulose came from. They're never making it themselves, and they're not chemically synthesizing it. That's way too expensive. They're always extracting it from one plant product or another. And I got some patients who, oh boy, they cannot tolerate corn extracted cellulose from, say, corn in Iowa, but you extract cellulose from corn in Mexico. They do fine with that. They can't tolerate cellulose extracted from rice in Thailand, but you give them cellulose extracted from rice in India, they do fine. There are all these different strains of all these different plants, corn, rice, all these crops that the cellulose is being extracted from, and the mast cells can tell the difference. And sometimes what you got to do, since the drug companies know where they're getting the cellulose from, but they're not telling you on the ingredient list because they don't think it makes any difference. And because the FDA doesn't make them tell you where it's coming from, because the FDA doesn't think it makes a difference. So you got to call up the consumer hotline at these manufacturers, and the secretary who answers is not going to know, but they can always patch you through to a pharmacist, and the pharmacist is not going to know the answer off the top of their heads, but they have access to the company's files, and they can always dig into the files and figure out where the hell the cellulose is coming from. And in my experience, most of those companies don't have any problems at all with doing this digging and telling the patients where these excipients are coming from. It's not a trade secret. They just don't release the information because they think it doesn't make any difference and nobody's interested in it. But some patients, they come to piece together these patterns. Oh my God, I'm reacting to cellulose from palm, but I don't react to cellulose from corn. And then they go through their medication lists and they do the digging, and oh my goodness, yes, this is a problem. And they don't change their drugs or the doses, they just change the formulations to avoid the troubling excipients. And just like that, they can go from being horribly miserable with all sorts of symptoms to doing remarkably better within just a few days.
That's super helpful because a lot of the compounding pharmacies use cellulose too to make their compounds. So that's good to know in case.
There are a lot. I mean, there's this. I'm trying to remember the name of it. It begins with Avicel. There's this one particular formulation of cellulose called Avicel. I think it's corn based. Not surprising that would be the most popular one because it's the cheapest. And corn, you can't get a cheaper crop than corn. But if there are patients out there who are reactive to corn, then they're gonna react to anything that has Avicel in it. But there are the compounder, a good compounder always has options. And so you press them. You say, try something out. For example, some patients who react to cellulose, there's this synthetic called Loxoral that sometimes can be much better tolerated. Yeah, it's synthetic, so it's more expensive, but And oh, by the way, regarding the corn, some of these patients react to a lot of the beef, the meat products that they eat, because the beef actually contains, trace amounts of the corn feed. And so those patients sometimes have to switch to grass-fed beef. I think we actually talked about this last time, if I'm remembering right. And some of these patients, they can't even tolerate grass-fed beef because most grass-fed beef is actually switched over to a corn feed in the last week or two to put on a lot more weight than grass feed can put on to a cow. And so some of those patients, they need to specifically get grass-fed, grass-finished beef. And then there are the patients who, nope, they're going to react to grass of a certain variety. It's like a grass pollen. And so they cannot tolerate grass-fed beef that comes from this particular ranch that feeds this particular type of grass to its cattle. But if they go get grass-fed beef from another ranch that uses a different type of grass, they tolerate that just fine. So
Yeah. Fascinating.
Is this easy to figure this out? No. Is this cheap to figure this out? No. But if you
I
don't
think it's
figure
fun.
it out,
I think it's
figure it out,
fun.
they're gonna keep having reactions. There's no getting around step one.
I wanted to sneak in a little question regarding treatment with cromolyn.
Mhm.
And as I was starting to manage patients with MCAS and learn a little bit more, cromolyn was one of the first ones I added after antihistamines. I felt it was pretty benign. And I have been noticing that higher doses in certain patients that respond well to it, higher doses have been really helpful, and not only with like the GI side effects, but the systemic effects too. And again, like you mentioned, I haven't been able to pinpoint which ones are these, but the itching, the swelling, the muscle aches, it's kind of those symptoms that I see that improve with the higher doses. My question to you is, how high do you go? Because
Right. Well, the manufacturer's official recommendation is a max dose of 200
200.
milligrams every every 6 hours. But I will tell you, I got plenty of patients who have tinkered and found 300, 400, 500, 600. Not that I'm setting out there a challenge for anybody, but just as a point of information, I will tell you that at the moment, my present record setter for cromolyn dosing is taking 800 milligrams of cromolyn 5 or 6 times a day. And she does that because she knows from experience if she takes any lower a dose or lower frequency, it does not help her nearly as much. And it's not that she's become addicted to it, that she's, ratcheting her dose up higher and higher over time. It's just in her initial experimentation with the drug, she realized the lower doses, they were helping minimally, and the higher doses clearly helped much more. What's different about her mast cells that requires such a higher dose of the drug to gain the same efficacy in her that would be seen with much lower doses in other patients? I don't have the foggiest idea. I'd love to study the genetics of her mast cells compared to others who use cromolyn at normal doses. It's got to be something different there, but the testing is not available yet outside
I
of a
feel a little
very
bit
few
better
research
because
labs.
I my boss Peter Rowe walked into FaceTime that I was doing with a patient, and I have her, she's on 800 4 times a day, and he was like, "Oh my God!" And I
No,
was like,
nothing wrong with it other
"It's
than,
working well," and he was like,
yeah.
"Great!
Now,
Why
just
don't you
one
light it
thing,
up?"
to be aware of, though, when you said it's tolerated well, that is true, except in one perspective. Be aware that this is a U.S. problem only, but here in the U.S., oral cromolyn, the commercially available formulations of oral cromolyn, all these ampules of liquid cromolyn, they are horrifically expensive. Somebody, whether it's the patient through copays or out of pocket or the insurer, somebody is probably paying at least and for a routine dosing at 200 milligrams 4 times a day, somebody is paying about $20,000 to $30,000 a year for that. And for 800 milligrams 4 times a day, it's probably at least double that. Yes. Okay. Now, it is an artifact of the insanity in US politics, because the fact is cromolyn is an old, cheap drug. But it turns out anytime you package a drug into a sterile, single-use ampule, you get to jack up the cost of it about 100-fold. Now think about this. Is there any real need for oral cromolyn to be in a sterile, single-use ampule? No, you're drinking it. It goes down to the stomach. There's stomach acid that'll kill any, small levels of contamination there. Makes no sense at all for it to be sterile. But the drug companies get to jack up the cost 100-fold. And the US is the only healthcare system in the world that will tolerate those sorts of shenanigans from the pharmaceutical manufacturers. Everywhere else in the world where they've largely got single payer healthcare system, the government paid healthcare systems, the governments do not tolerate this. So in every other country on the planet, the commercially available cromolyn formulations are standard tablets and capsules that are cheap, and that's how cromolyn is done everywhere else but in the US. In fact, I know many patients here in the US where when they actually go to get cromolyn compounded, and again, cromolyn's an old cheap drug, so the raw powder is pretty cheap. And even though the cost of a compounded product often is not covered at all by insurance, many insurance plans, nevertheless, the copay that some patients have to pay for the commercially available cromolyn, even if it's only 10%, nevertheless, 10% of a $20,000 a year bill is an awful lot of money. Some patients come to find that paying 100% out of pocket of the cost of compounded cromolyn can actually be way cheaper than the copay for commercial cromolyn. So
Nice.
it's insane.
And just a little follow-up from the compounded forms, I have had some experiences where they put them on oil. Have you
I'm
ever
sorry,
heard of
say that
they
again?
put the cromolyn in oil? So they send it to the patient like in an oil compounded form, which was strange. I was just wondering, have you noticed, is
Oh,
it better on the pill, liquid, or a specific way of
no,
compounding it?
either the patient asked for that because the patient knows that that particular oil, whether an olive oil or some other oil, already is a well-tolerated excipient, or the compounder chose that formulation because of some financial incentive. But it really otherwise doesn't make a whole lot of sense, because the cheapest way by far, I'm not a pharmacist, okay, let alone a compounding pharmacist, but my understanding is that the cheapest way by far for a compounder to prepare a compounded medication product is in a capsule formulation. They take the amount of the drug that the patient is going to need for a month or so, and they put that in the bowl, and then they add in the amount of excipient that's going to be needed for a month. They mix it very thoroughly, and then they aliquot out of the mixture the amount of the mixture that contains the right dose of the drug, and they have these automated capsule loading machines that just automatically they dial the right dose into the machine, and the machine then just churns out all these capsules that are loaded with the right amount of the mixture, so that you've got the right dose in each capsule. And it's very slick and fast. It's very cheap for them to do that. So for them to prepare a compounded formulation in any other fashion, like a tablet or a liquid, whatever, it's usually much more laborious. That's more the pharmacist's time. It's more expensive. So unless the patient asked for that, or pharmacist has got maybe some financial reason to do that. I don't know why cromolyn would be provided to that patient in an oil rather than just in a capsule.
All right, so our next question is from one of our attendees. So Troy Roach, I'm bringing you up. Go ahead whenever you're ready.
Right. Hello.
Hello.
So I have a question related to the H1 meds that cause sedation, because I had one of the users on my Facebook page said that they started taking anti-motion sickness pills that are sold under the brand name Quells, which is scopolamine. And this medication was helping them quite a bit. And I noticed that the H1 medications are also affect the muscarinic receptors. So maybe the benefits from this might in part have to do with the effect on the cholinergic system and less on the histamine side.
That is a possibility, but when you give somebody scopolamine and you see not only anticholinergic effects, but you're also seeing downregulation of, a variety of other symptoms that are much more likely to be mast cell driven rather than cholinergic, mast cell mediator driven rather than cholinergic, then it's not necessarily that it's exclusively an antihistamine issue. These drugs that target multiple receptors, they may be bringing benefit through multiple mechanisms in parallel. That's always possible. But yeah, I've seen a few patients who, in fact, it's funny you bring up scopolamine. I actually saw a patient about a week ago who had known since she's had motion sickness since early in childhood, and she learned early that she had not only nausea with motion sickness, but she had flushing and urticaria and all sorts of these other issues that clearly were mast cell driven whenever she was in a car for a trip or a plane. And the scopolamine settled down not only the nausea, but all these other things. And my bet is, yeah, there may be some anticholinergic effects going on there, but probably the scopolamine's engagement with the H1 receptors on the mast cells is probably contributing as well.
And
There's
is
very little in
scopolamine
human
typical?
biology that's black or white, all different shades of gray in pretty much everything you look at.
And is scopolamine a typical medication that your patients might use?
I have a very few patients on scopolamine. Usually when they're using a sedating H1 blocker, we use others, hydroxyzine or cyproheptadine, so on and so forth. But occasionally, scopolamine can be used.
Okay, thank you.
Mhm.
Right, so our next question is from one of our anonymous attendees, and this one is on DAO. Is the DAO testing accurate, and if so, what type?
Yeah, there's only one way to get DAO tested here in the US that I'm aware of. There's a specialty lab down in Georgia, in Dunwoody, Georgia, place called Precision Point Diagnostics. They offer DAO testing as part of a panel. They also do in that panel a plasma histamine assay, a zonulin assay, and they also look for IgG, A and M isotypes of anti-lipopolysaccharide antibodies. And as to whether it's accurate or not, I don't know that I have any way to assess that. I'm not sure I can say that I've seen clear correlations between patients with mild degrees of DAO deficiency versus whether they're going to respond to DAO supplementation. My much fewer patients who have very severe deficiencies of DAO, I actually do often see some improvements in them with when DAO is used shortly before each meal, particularly the meals in which they take foods with higher histamine content in them. Less clear to me how predictive that testing is when it's only mildly abnormal.
Is there as a follow-up, is there a particular accessible lab panel that you found to be the most useful? So there at this point, there's so many direct-to-consumer or non-CLIA research-only lab panels out there. Are there particular ones that you found to be really the more useful?
We're testing for what?
For testing on a patient with MCAS.
No, I mean, for many of these mediators, you have very few choices of laboratories that will run, that are able to run these mediator tests. For example, up until just very recently, at least, prostaglandin D2, for many, many years, the only place in North America that could run prostaglandin D2 testing was InterScience Institute in Southern California, just outside of LA. Just very recently, I think LabCorp and Quest have started doing prostaglandin D2 testing. Leukotriene E4 testing, to my knowledge, is only available at Mayo, and not even the different Mayos, just Mayo Rochester. So if you want to get that tested, you need to work with a laboratory that's going to be willing to send out to Mayo. 2,3-dinor-11-beta prostaglandin F2 alpha. It's only one laboratory in North America that's going to measure it, and that's again Mayo Rochester. Plasma histamine gets tested at a different place than blood histamine. Random urine histamine gets tested at a different place than 24-hour urine histamine. Who would imagine such craziness? But this is the way it is at present. I think there's a hell of a market, given how prevalent we're learning MCAS is, I think there's a hell of a market for some laboratory to set up sort of a package where a panel, like you mentioned, where you send, all your specimens to this lab. They're well trained. They know how to handle the specimens properly. And, hopefully they can do a good job. But, that requires the directors of those labs, the pathology and lab medicine physicians who operate those labs, and the businessmen who run those labs, to become aware that there is this disease, MCAS, and it is a prevalent disease. It is a huge market opportunity. I don't know what else to say about that. So, when I order tests, I have my nurses, draw the blood and the urine samples here in the office. We take very good care to keep everything chilled. We invested in a very expensive refrigerated centrifuge. So when we're separating out the plasma or the serum, it's happening at chilled conditions. And then we pack things up, and we have a courier come, takes most of it to the Northwell system down in New York City. But very few of these tests are actually done by them, and they just bank it for a day or two in their freezers and pack and lump it all together with other shipments that they're sending out to Mayo or Salt Lake City or whatever. And it just all goes out in batch. And I have to pray that Northwell and all the other downstream people, that they're doing the right things on handling these specimens. So I'll be the first to acknowledge most of the results I get back, they're normal or negative. And I don't know if they are true normals, true negatives, because that particular mediator is just not really involved in driving the symptoms in that patient. or at least not at the time that we were collecting the specimen, or whether maybe it's a falsely low level that just appears normal. I have no way to make that distinction. I look for the elevated mediators. If it comes back normal, it's not helpful. If it comes back elevated, it's helpful. Now, to be fair, if I get back, an elevated mediator level that's just trivially elevated, no, I'm not going to go make a definitive declaration of this important life-changing diagnosis based on such a trivial abnormality. But nevertheless, I also am aware of just how technically challenging it is to get accurate levels of these mediators. So even if I find, I won't make a diagnosis based on a trivial elevation, but even just a mild elevation, say 10, 15, 20% elevation above the upper limit of normal, it's a mild elevation, but it's not a trivial elevation. And because there's no way to get a false elevation, you can only get falsely low levels, then even those mild elevations, they're significant. And they tell me there's some degree of mast cell activation going on there. Did that answer the question?
Yes, thank you. And Isabel's going to ask a question from the anonymous, or from the attendee that's not able to speak. So go ahead, Isabel.
Yeah, so this question is from Debbie Larson. She wasn't able to stay. It's a long question, so bear with me. So it says, according to studies, sodium cromolyn influences tendon repair and extracellular matrix gene expression following acute injury in animal models. The sodium cromolyn injections moderated the structural alterations of healing tendon in association with downregulation of several genes associated with tendon fibrosis. Based on studies of ketotifen, treatment in animal models, disruption of mast cell contributions to the fibrotic process leads to decrease in SP-containing nerves and reduced mast cell and myofibroblast numbers. Mast cell hyperplasia was also significantly reduced. The ketotifen treatment also reduced TGF-beta1, collagen type 1 protein. This was with twice daily subcutaneous administration of ketotifen given immediately post-injury. Early interruption of neuropeptide mast cell myofibroblast axis may be crucial to halting the fibrogenic process, and so treatment needs to be done immediately post-surgery. And then the part 2 is, has anyone ever tried injecting cromolyn and ketotifen post-surgery to ameliorate the inappropriate healing response, which often leads to permanent disability in some EDS MCAD patients? If not, why not? Would there be any harm in experimenting with this?
I'll be honest, I didn't even hear a question in the first part. I heard a lot of statements. I didn't hear, what was can you see again what the question was?
The question was in part 2. Has anyone ever tried injecting cromolyn?
That I can answer. And I have heard, pure hearsay, nothing better, that there have been many efforts over the last at least quarter century to develop IV cromolyn, or even intramuscular cromolyn for various human uses, and it has never come to market. And I have no idea why that is, whether the trials failed and at what stage they failed. But the bottom line is, this is something that has been looked at a long time, and it has never come to fruition. And that's with regard to cromolyn. I actually have never heard about any trials regarding IV ketotifen. I don't know what to say about that.
Okay, well, thank you. So next question is going to be from one of our anonymous attendees. So how big of a proportion of your MCAS patients who try brain retraining see some improvement? How to reconcile between avoiding triggers and following these programs?
Yeah. I don't know that I've specifically examined my charting system to come up with a specific percentage, specific answer to that question. My gut sense of the matter is that it's roughly a flip of a coin. But at the same time, let me also mention this important point. The different limbic system retraining programs very clearly come at the notion of retraining the limbic system from very different philosophical perspectives, and the nature of the exercises that are prescribed in the different programs is quite different from one program to another. And I can tell you that an awful lot of mast cell patients, they very much take a liking or a disliking to one program or another. And I have seen, for example, there's this one very popular program out there, the DNRS program, the Dynamic Neural Retraining System program. There's no question there are a lot of patients who like it. They found very good benefits from it. But I've had some patients who they just hate DNRS. I've come to understand that one of the central tenets to DNRS, one of its philosophies, is that if the patient's going to have success with limbic system retraining, they need to basically ignore. They have to learn to ignore that they have a disease. And for many mast cell patients, that's understandably very difficult to do. And so, just as an example, I had this one patient not too long ago out in Texas, out in Texas somewhere. And she wanted to try she had a lot of food reactivity. She wanted to try one of these programs. She heard about the popularity of DNRS, didn't really investigate what its philosophies were before she got the training materials, and she was only a couple of weeks into it. And she said, "This is ridiculous. I can't ignore that I'm sick. It's part of me 24/7. I can't escape it." And so she went casting about for an alternative program, and there's this other one I provide my patients a list of many of these programs as just a starter set of these programs they can go looking at. And there's this other program that has kind of the opposite philosophy to it. It's called the ACT program, the Acceptance and Commitment Therapy program, where you have to accept. Some people, they want to deny that they are sick, deny they have a disease. This program teaches, no, you have to accept that you have a disease and then commit to doing what has to be done to fix it. And so this patient switched from DNRS to ACT, and she said in just a month or two, she couldn't believe how much better her food intolerances had settled down. So listen, I'll be the first to acknowledge that the science of what's going on with these programs, what they're actually doing in the neurons and the mast cells, remains far more voodoo than anything else. But at the same time, when you look at the anatomy of this, where are the mast cells in the body? They are directly abutting all neurons, peripheral and central, and you begin to realize, and there's constant mediator crosstalk going on between all the mast cells, all the neurons in the body. So you can begin to understand how if you change the neural reactivity patterns, sure, there's ample potential to start changing how the mast cells are behaving and misbehaving. I don't know what else to say about those programs.
All right, thank you.
Actually, let me take this opportunity, give you one example of how extreme the improvements can be. I had this one patient one time. She was so reactive to foods, and in particular citrus, And she had so many reactivities, she was essentially confined to her bedroom on one side of the house, 24/7. And if anybody brought any, such as say a lemon, into the kitchen on the other side of the house and put it in the produce bin in the refrigerator, and then if anybody opened the refrigerator, not necessarily opening the produce bin, just opening the refrigerator. And believe you me, it took a long time to figure out this pattern, but 20 minutes after the refrigerator door was open, she would very reliably start having a flare, her symptoms. And it was clear that the lemon zest, the citrus zest, was escaping from the fridge, wafting about, in the particular pattern of air circulation in the house was such that 20 minutes after the refrigerator was open, the citrus zest would get into her bedroom. And so she started, I think she actually did do DNRS, and she was unusually precocious. Most of these patients take about 3 to 6 months to start getting better with these programs, but in just 1 month, she was not only able to hold a lemon in her hand, she was able to slice it open and suck at it with no reactivity whatsoever. It was unbelievable. So sometimes these responses can be quite dramatic.
Definitely. Okay, our next question is from Sam. In addition to the advice to make one change at a time, what do you think about retrialing exposures or treatments? Do mast cell stabilizing treatments tend to show different success rates in the responses of individual patients, or is a failed treatment not worth retrialing?
No, that's an excellent question. And I explicitly teach all my mast cell patients, I never have any problem with them retesting their ability to tolerate something that previously had pretty obviously become intolerable. Anytime they have gained some obvious improvement in any aspect of their disease, I never have any problem with them retesting whether their ability to tolerate some trigger might have also improved in parallel. They obviously need to do such retrials cautiously to start with, so that if they do still have a vigorous reaction, it's going to be, as modest as possible. But I haven't learned yet any patterns that tell me that, oh, you apply this drug or you see an improvement in this particular symptom, and that's going to mean, oh, they now can definitely, very, very confidently are going to be able to now tolerate some particular exposure they couldn't previously tolerate. I haven't figured out any of those patterns yet. But nevertheless, you get better control over the disease, which becomes evident in that at least some of the symptoms are improving. And it absolutely raises the question of whether some of the reactivities might have settled at least somewhat. And so absolutely go try, just be cautious about it to start with. Some experiments will be failures for sure, others will be successes. And I've seen many of these patients who have managed to regain good amounts of tolerance for lots of things that had previously become utterly intolerable. Some people, they also approach this from the perspective of pursuing desensitization therapy protocols with allergists. Nothing wrong with trying that, but again, set expectations ahead of time. Some of these patients, they're going through desensitization protocols for 2 years, 5 years, 7 years, and they're just not making any progress. And pardon me for thinking the allergist is doing this because he makes a mint off it. If you're not seeing improvement after a year or so, you need to re-question the value of the treatment, the likelihood that further persistence with that treatment is actually going to make a significant difference. Desensitization can take a lot longer than results you see with any particular drug. It can take many months, but you know, if you're 6 or 12 months in a desensitization, not seeing any significant reduction in reactivity to whatever the target of that treatment is, then I think you're justified in saying, look, we need to stop this and turn our efforts, our resources in other directions that may have a better chance of bringing significant improvement.
Excellent, thank you. And another question from anonymous attendee is, why do different H1 blockers have different effects? Is it because they have an effect for not only histamine, but to other mast cells mediators as well?
Yeah. There's at least one H1 blocker, rupatadine, available on the European market and Canada at a minimum, but not here in the US, unless you order it either from those other countries or get it compounded. That actually does address more than just the H1 receptor. I talked a little bit earlier in this presentation about how rupatadine goes after some other mast cell surface receptors like the PDGF the receptor that can also be helpful in settling down not only mast cells but also eosinophils. But as to the larger question of why different H1 blockers are going to help different patients, different symptoms of different patients, and you could say the same thing with the H2s. You could say the same thing with the benzos and the SSRIs. I mean, fundamentally, no matter what class of drug you look at, fundamentally, each different drug in a given class is a different molecule. And the different molecules are going to come to engage with the target receptors in a slightly different fashion. And for many folks, those subtle molecular differences actually wind up making a significant clinical difference. I wish we understood the molecular biology of this well enough so that I could predict which particular H1 blocker is going to best help a given patient. And same thing with H2s and leukotriene blockers and benzos and so forth. But the understanding of the biology is nowhere close to that point. So it takes some time to work through the options in each category, but these patients generally are going to live a normal lifespan, so they got the time to go figuring out the best drug in each class. So if you're going to live another, 40 years, why would you want to go even the next 4 years, let alone the next 40 years with what might be a suboptimal H1 or H2 blocker, a benzo, and SSRI, especially since many times the difference in the benefits between the best drug of a particular class versus the second best drug in that class, sometimes the differences are stark. I give you an example. I've had, you know that ranitidine was taken, the H2 blocker ranitidine was taken off the US market about 4 or 5 years ago. It was an utterly bogus thing. And ultimately it got shown that it was a totally nonsensical thing. And in the last couple of years, ranitidine and similarly nizatidine started coming back to the market. But I had some patients who they had gone through these trials, these systematic trials of the different H2 blockers before ranitidine and nizatidine got taken off the market. And they had learned very well that ranitidine served them starkly better than any of the other H2 blockers, famotidine, cimetidine, nizatidine. And they were in my office in tears when they learned that ranitidine was being taken off the market, because they had learned well just how much better ranitidine was settling down a wide range of their symptoms compared to the other H2 blockers. So they did a lot of hoarding and panic buying, but eventually their supplies ran out and they had to resort to one of the other H2 blockers, and sure enough, they lost a lot of the benefits they had been getting from ranitidine. And then when I was able to tell them a couple of years ago, hey, guess what's coming back to the market? You should have seen the smiles light up on their faces. And, they went and got back on ranitidine as quickly as they could. And sure enough, much different experience. And I don't want you to go thinking that ranitidine is the cat's meow among H2 blockers on a reliable basis. It's not. I got just as many patients telling me famotidine is the cat's meow, and ranitidine does nothing for them. You might think cimetidine has zero chance of being the best H2 blocker because it has by far the shortest half-life of all of the H2 blockers and way more drug-drug interactions than any of the other H2 blockers. But I've got a small proportion of mast cell patients, maybe about 5–10% of them, who've done these systematic explorations of the different H2 blockers, and they come out the other end of it saying, there's no question, cimetidine is absolutely my best H2 blocker. So then, you have to make accommodations for it because it's got a lot of drug-drug interaction. So if you go prescribing other drugs, sometimes you have to adjust doses to accommodate for the fact that they're on cimetidine. But if they know cimetidine serves them better than the other three, then if they're gonna live another 30, 50 years, let them enjoy cimetidine.
All right. So our next question coming up, thank you, is from Patricia. Patricia, whenever you are ready.
Hi, thank you for this presentation. It's excellent. And I have a question as far as what you might attribute to being on, successfully being on Avastin at 10 milligrams, seeing improvements.
I'm sorry, I missed the drug name.
Avastin?
Oh, Avastin. Yeah, that's
Avastin, excuse me.
one of the non-sedating H1 blockers available in Canada and some of the European countries.
Right. I've been fortunate to try it and have had good improvement on 10 milligrams, and then tried upping the dosage to 20 milligrams and had an extreme reaction. And I'm wondering, burning of the inside the nose, everything below the eyes.
If you're having a burning on merely what's almost certainly going on is there is some excipient in that particular Avastin formulation that is a trigger for your dysfunctional mast cells in a fashion that can potentially bring about this, release of inflammatory mediators in a fashion that gives you that sensation of burning. But the amount of that excipient that's in the 10 milligram product is not enough to, you take too low a dose of anything, it's not going to do anything for you. It's not going to have any effects in you. So there are thresholds for everything. So probably there's some excipient in that formulation that whatever amount of that excipient is mixed with the 10 milligrams of Avastin in each, tablet or capsule of that product is just not enough of that excipient to go triggering your dysfunctional mast cells to produce that burning. But then you double the dose of the drug, you're kind of inescapably also doubling the dosing, simultaneously doubling the dosing of each and every one of the excipients in there, and you're probably crossing a threshold at that point with one of the excipients. So, there aren't all that, there are far fewer formulations of Avastin out there in the worldwide market than for many of these other H1 blockers. So I don't know how difficult or easy it would be to find some alternative formulation that has a different excipient package, but strikes me what you ought to do is look at the ingredient list of your current Avastin formulation, try to figure out which, do the best you can to try to figure out which excipient is more likely the trigger, and then see if you can find another formulation that just does not contain that same suspected triggering excipient, and then go try that other product, see what happens. Worst case, maybe Avastin is available compounded, but again, it's a relatively uncommonly used H1 blocker. I don't know whether the powder, the pure drug powder, is actually available for purchase by compounding pharmacies. You'd have to ask a compounder about that.
Okay. because I have the tablets are 20 and I've been splitting them.
Okay. Well, it's the same concept though, you know.
Right, right. So would it make sense though to like try the 15? I was kind of scared off by the 20.
Nothing wrong with doing that. I think you'll learn pretty quickly whether it
Okay,
makes a difference or not.
right.
But honestly, since I mean, you can try 15 if you want, but to my mind, every time you take that product, even if you're taking the half a pill, the 10 milligram pill, you clearly are taking, there's something in there that's a trigger.
Uh-huh.
And to my mind, if you have a choice, the better approach would be to take another formulation that does not contain the trigger at all.
Sure, of course.
So
Accessing it is the hurdle though. And I am seeing the benefit by taking the 10 milligrams. So it's kind of,
yeah, you might want
Picking
to just contact a few compounding pharmacies and just
Mhm.
see if it's even available for compounding. I would not, if the first place you call says nope, not available, I would not necessarily take that as the be all and end all of it. I learned a long time ago that when you call up one compounder and they say they tell you sorry, that's not available. It quite often is the case that when you call other compounders, they say, yeah, no problem. What they're actually telling you when they tell you no, it's not available is that whatever raw drug powder distributor they are contracted with does not offer that product. And so, different compounders are going to contract with different distributors, and therefore different compounders have access to different drugs. So it often pays to call around, do some, comparison shopping, so to speak.
Mhm. Okay, appreciate that. Thank you.
All
Oh, let
right,
me
thank you.
mention, I'm sorry, let me add one other point too, regarding that comparison shopping point. I learned the hard way a long time ago too, that sometimes there can be starkly different prices for exactly the same compounded product, the same drugs, same fillers, same everything's the same, but two different compounders may offer very different prices on it. So sometimes it really does pay financially to call around, do some comparison shopping before you decide exactly which compounder you're going to get a given product from.
All right, excellent. Next question is from anonymous attendee. You mentioned that topical treatments can be compounded at home. Can you give more information on how to do that?
Yeah, well, some of them can be compounded at home. For example, some people who've got various various wounds or lesions that are just not healing well, and they want to try applying some cromolyn cream to them. They go get a jar of whatever. I mean, there are recipes on the internet for doing this, but what it boils down to is get a jar of whatever skin cream you already know you can tolerate, like Eucerin, for example. And you then get a bottle, an over-the-counter bottle of cromolyn nasal spray, and you open up the bottle and you pour the bottle into the jar and you mix it carefully, obviously, and congratulations, you now have home compounded cromolyn cream. And some people find that then when they then put that on their non-healing lesions or wounds, oh boy, they start healing. Some people have a lot of issues with the scalp and hair loss from this disease. And oh, by the way, you may be interested to know there's some old literature showing that And who knows why people choose to study this sort of thing, but it turns out that an awful lot of people with mysterious hair loss, they happen to have detectably elevated levels of prostaglandin D2 in their scalp tissue. And given that there's only one type of cell in the human body that can make any significant quantities of prostaglandin D2, you know, the mast cell, it's obvious the mast cells are involved in driving that hair loss. And I have no end of these mast cell patients who tell me that they're absolutely having excessive, you know, unusual hair loss, hair thinning. You know, they come out of the shower every time and there's just clumps of hair in the drain. And you can't go just based on how you see the patient. The patient knows their hair way better than the doctor will ever know it. So the doctor often looks at them, they look like they got a full head of hair, but the patient knows well they used to have way more hair, much thicker hair than they've got now. So some of these patients, they make up a home compounded cromolyn shampoo. They take a bottle of whatever shampoo they already know they can tolerate, and they pour in a bottle of nasal cromolyn or eye drop cromolyn. They mix it up, obviously carefully, otherwise you'll lather it up like crazy. And at that point, congratulations, you got home compounded cromolyn shampoo. And some people find they take, you know, 1 or 2 showers a day with their cromolyn shampoo, and the hair starts growing. But at the same time, you know, keep in mind there can be other causes for hair loss. We talked, for example, about how there can be micronutrient deficiencies in some of these patients. And, you know, for example, that B5 and B7 are integral to proper hair growth. So I have found some patients who've got significant B5 or B7 deficiencies, and you go supplement that, and then their hair and their nails start growing properly. You always have to be careful with it. It's so easy to just reflexively blame every problem in them directly on the mast cells, but just because they got a mast cell problem doesn't necessarily mean they can't have other problems. So you got to be running through the differential diagnosis for every problem they're telling you about. Think of what else might be in the mix here that warrants relevant diagnostic testing, and, you know, other treatments that are not necessarily targeted specifically at the mast cells.
All right, thank you. And our next question comes from one of our attendees, Andrea Grabov. Andrea, you're up. Sorry, I started
Thank
flubbing on
you.
that one. I'll let
Thank
you go.
Thank you so much. I'm really curious. My background is as a psychiatrist, whether you've observed any relationship between individuals with higher oxalate levels and associated inflammation and MCAS. So are these conditions completely independent of each other, or is there some other connection possibly other than kidney disease? And I'm asking because when I work with families and multi-generations, it seems to me that clinically I see these two together more often than I would expect, just statistically. But I'm curious as to your observations.
Well, my experience has shown there's little question that mast cell disease can drive it can drive nephrolithiasis, you know, kidney stones in general. And of course, we've long known that about 80 to 90% of all kidney stones are calcium oxalate stones. And I have seen quite a number of mast cell patients in whom there clearly are elevated oxalate levels. You got to be careful in those patients with vitamin C supplementation. But if you're asking what is the specific molecular mechanism by which mast cell activation might be driving increased oxalate production and decreased, you know, oxalate excretion, so that you wind up with these higher oxalate levels, I don't think anybody has a clue yet. Not that I'm aware of yet. Now, that having been said, since you're a psychiatrist, I do want to take advantage of the opportunity to pivot a little bit to another psychiatric disease that you folks often deal with, bipolar disease. You may want to start taking, if you haven't already done this, a closer look at your bipolar, specifically the bipolar type 2 patients, who almost always, with their odd unipolar type bipolar disorder, it's almost always depression rather than mania that they've got. But my own experience, and I've started hearing this from at least a few other MCAS aware psychiatrists over the last, 5, 6 years now, that it's turning out that almost 100% of the bipolar type 2 patients, they've got MCAS. And many times when all the psychiatric treatment, the classic psychiatric drugs in the world are just not getting any improvement over the bipolar, the depression of those patients, you get them on, mast cell targeted treatments of one sort or another, and finally you start seeing improvements in the depression. So I just wanted to mention that to you since you mentioned you're a psychiatrist. That's something. Again, these cells, they're abutting all the neurons, including the central neurons. They can drive a huge array of neurologic and cognitive and psychiatric and dysautonomic issues. Actually, it's very common to see psychiatric issues in these patients. The most common types are the anxiety and the mood disorders, either depression or bipolar. But when you see these issues in a mast cell patient, it's not that there's anything fundamentally wrong with the neurons. There's no primary abnormality in the neurons. It's that the mast cells are releasing these mediators that are hitting on the neurons in a fashion that's driving the observed psychiatric issues. I can understand how there might be some natural reactive anxiety in these patients when they've seen countless doctors, can't get any explanation for their problems. Most of their doctors are denying the reality of their symptoms, and they've tried a million treatments and not gotten anywhere. I understand all that drives a natural anxiety, may even drive a sort of a medical PTSD. But the great majority of these patients, they'll tell you they get anxiety, flares of anxiety and panic just come out of nowhere, no reason whatsoever for that flare of anxiety and panic to have popped up at that point. And it's not a primary neuronal issue. It's almost certainly a flaring of the mast cell disease. In those situations, at least for their flares, get some extra H1, H2 blockers, particularly an H1 blocker that can get into the central nervous system, like some diphenhydramine. Get that in there as quick as possible. Liquid or rapid dissolving formulation is probably even better than regular tablets or capsules. And you'll probably settle down that flare very quickly. Wouldn't it be wonderful to do a study of frequent flyers in the ER who come in all the time for these panic attacks, and they've had all the medical workup in the world and you can't find anything medically wrong with them, and they get dismissed as psychosomatic or primary anxiety disorder, and yet the psychiatrist can't even help them? Wouldn't it be wonderful to do a study of 20, 30, 50 of them, just run an MCAS workup, and then to be able to publish a paper, if nothing else, just publish a paper that says X% of all of these mysterious panic patients have a detectable MCAS in them? Wouldn't that be a novel development in the psychiatry literature?
That would be amazing.
So it wouldn't be hard to do. You could even start just by doing it as a case series. Do you have any of your patients who are frequent flyers with panic or anxiety?
I do, and often, again, there are so many multiple comorbid medical
No,
conditions.
I understand that, but at a bare minimum, why don't you just take a series of them, 5 or 10 of them, and just run the workup in them, and then you publish a paper, just a case. It's not a study, so to speak, not a prospective, controlled study, but just to start with. You say, look, I examined 10 of my frequent flyer panic patients in whom no other cause could be found, and oh my God, it turned out that in 8 of them, I could identify a laboratory provable MCAS. And oh yeah, I looked at the rest of their histories, and it turns out they've not only got anxiety, they got 573 other symptoms that
Yes.
can't possibly be explained, psychiatrically, but can be easily explained by mast cell activation. You put that paper out in the literature, and it'll perk up the attention of the more prominent researchers to say, maybe we've been missing something. And then those people will then run with the ball and start running the more prospective and the larger studies that will flesh out all the details of this. But it's got to start somewhere. The idea. See, nobody has a reason right now, based on what we're taught about mast cell disease in our training, based on our experiences in practice, nobody has a reason to go thinking that MCAS might be a cause of anxiety and panic in a non-trivial proportion of the anxious panic patient population. Nobody has a reason to think that. So you put out a small case series that says, oh, this is a new idea. And then everybody else who out there, all the researchers who are starved for new ideas to explain this, here's a new idea. And oh yeah, it actually makes biological sense. It makes anatomical sense. It's just they never had a reason to think about it before. So you can do that.
Thank you for the inspiration. And I'm sure it's not just myself as a clinician that has the gears whirring now. I'm sure there's many others as well.
Oh,
And,
absolutely.
and so very open also to any collaborations. And thank you again for your time
Absolutely.
and sharing your expertise.
My pleasure. Thank you for tuning in to something that you might ordinarily think couldn't possibly intersect with psychiatry.
All right. Well, our next question is coming from another anonymous attendee. And this one is about COVID. So how worried should MCAS patients be about COVID exposures and infections if they're on several mast cell stabilizers now? It's hard out here in the world navigating COVID consciousness given the failures of Western world to protect us vulnerable patients. Should we consider monoclonal antibodies like Pemgarda, previous Evishield?
Yeah, it's a great question. Thank you, whoever asked it.
Okay, I've had my on.
There's no question there's something about the COVID virus, whether it's the spike protein or something else, that hasn't been figured out yet. And the same thing with the very immunologically similar COVID vaccinations. There's something about some molecular aspect to the virus and the vaccines that is a potent trigger for activating mast cells. You don't have to worry about what the virus and what the vaccines are doing to normal mast cells. Normal mast cells are handling it fine. They activate a normal amount. You get some inflammation. It settles down after a few days, no big deal. The problem is when the virus and sometimes the vaccines hit the dysfunctional mast cells. And to be even more specific, I've learned well, it's not really a matter of whether the patient just has dysfunctional mast cells. What matters is whether the virus or the vaccine hits a patient who has insufficiently controlled dysfunctional mast cells. Because if you get the mast cell disease under at least halfway decent control, and quite often that takes nothing more than H1 and H2 blockers to accomplish it, then those patients just have kind of a normal response to the virus or the vaccine. I've had many patients who had, as you might imagine, they had come to be diagnosed with mast cell disease and treated well before the pandemic broke out. But it's a widespread, it's a pandemic and it's highly contagious. So no surprise that many of my mast cell patients did come to suffer the infection. And of course, many of them have gotten vaccinated too. And so far, I have not seen a single one of my halfway decently, no, I can't quantitate that. I can tell it to you clinically. But I have not seen a single one of my halfway decently controlled MCAS patients come to suffer an unusually severe acute course of the disease, one of these so-called, hyperinflammatory cytokine storms. Not a single one of them has needed a ventilator. Not a single one of them has died. And not a single one of them has developed long COVID syndrome from either the infection or the vaccine. But the patients I have who only come to me to be evaluated for MCAS after they got the infection or got the vaccine, and they either had a severe acute infection or they developed long COVID syndrome. They are the ones who, I mean, long COVID syndrome almost certainly is an escalation of pre-existing MCAS. Liz, I promise you, you go do a deep dive into the history of any of these long COVID patients who will swear to you initially, I was perfectly healthy before I got COVID. You do a deep dive into the history of those patients, and I will be shocked if you truly find they previously were perfectly healthy. They may have been getting along okay and functioning in life and all that, but you do a deep dive and I'll bet you'll find plenty of issues they had been having with their health for years and years and years and years, and nobody knew what was causing it. No treatments were helping, and they just learned to live with it. Then they got hit. So they had all these dysfunctional mast cells all along, but they were unrecognized as dysfunctional, therefore undiagnosed, untreated, and therefore uncontrolled. And then they get hit with a major stressor, a major immunologic stressor, and they may have a severe acute course of the infection, and it's the dysfunctional mast cell, the uncontrolled dysfunctional mast cells that are reacting wildly inappropriately to the virus and sometimes the immunologically similar vaccine. And it's likely the major stressor from that, acute infection or the vaccine that is then driving one of these escalations. So they were cruising along with the MCAS at some lower level, maybe their entire lives. And then they got hit by the virus or the vaccine, and it goes boop up to a whole new level. And this is, coming to be labeled as long COVID syndrome. But I've had a lot of long COVID patients come to me, and you do the diagnostic workup for MCAS in them. Honestly, I don't think I've seen one yet in whom I could not find clear multiple points of laboratory evidence of MCAS in them. And then we treat them with MCAS targeted therapy. Sometimes it's as simple as antihistamines that gets them significantly better. Sometimes we need to add in some other drugs, but most of them do find some cocktail of mast cell targeted drug that actually does get them doing significantly better. I can't make them perfect, can't make them significantly better 100% of the time. There's always going to be some ups and downs. But most of these people find some cocktail that gets them doing significantly better.
Well, it's an interesting concept, the interaction between the activated mast cell and the inflammatory driver, and the toll-like 4 receptors that the spike hits will drive that inflammation. And then if you get localized hypoxia because of little microclots and things, that will continue driving inflammation. But I'm not sure that I've ever heard anywhere the concept of trying antihistamines early on as in the acute phase of an inflaming COVID acute infection. And there's reason to think that it could keep the whole local tissue quieter, which might get you through the tunnel of the acute COVID. And that it looks like metformin definitely does that, and it looks like its activity is more on the TLR4, but they might be very, very complementary.
Actually, when just a couple of final comments on this COVID point. Actually, very shortly after I published my first paper, just initially hypothesizing that an underlying MCAS might be what's accounting for much of the severe acute infections that you see in about 15 to 20% of COVID patients. Again, isn't that a curious percentage, given that we're finding the prevalence of MCAS in the general population is about 15 to 20%? What's different about those patients? Why do they have the severe acute courses and the other patients don't? So I published this hypothesis paper that maybe it's unrecognized pre-existing MCAS, uncontrolled pre-existing MCAS, that is what's driving the severe acute infections and the long COVID. And at the end of the paper, I suggested that maybe something as simple as just antihistamines will be very helpful these patients. And within days of that publication, I started getting emails from health professionals all over the world who had come to suffer a long COVID syndrome, and they were disabled, nothing could help them. And some of these people, they read that article, they went out that day to the CVS and got some, Zyrtec or Claritin, and they were writing me all excited because in 24 hours, they couldn't believe how much better they were feeling. Does that prove they have MCAS? No, you still have to do the testing in them, but boy, that's suggestive. Now, finally, one other point on COVID, because part of the question was, what else do you do to manage COVID in an MCAS patient who's already being treated for the MCAS? And the answer to that is, remember how I said that the likelihood of when you encounter a severe stressor, the likelihood of that stressor actually sparking an escalation, a sustained escalation of the disease, the likelihood of that seems to be modulated if you already have the disease there, the MCAS under better control at the time you go through the stressor. That's true. So you do the best you can to get the MCAS under control. But then when you get hit by the virus, the bottom line is it's a potent stimulus, potent immunologic stimulus, driving an awful lot of physiologic stress in the body, a lot of inflammation, and you want to get rid of the stressor as quickly as possible. So kill the virus as quickly as you can. So right now, the best tool that most of us have access to getting that done is Paxlovid, a combination of these two antiviral drugs that can kill the virus. And I will tell you, I've learned the hard way, the standard 5-day course of Paxlovid, not enough for a mast cell patient. A mast cell patient really needs to be taking a 10-day course of that, even if you have to get it prescribed as 2 5-day courses, but you got to take it as a 10-day course. Otherwise, I'm not going to say every mast cell patient who takes a 5-day course is going to have a rebound of COVID, but an awful lot of them do. And in my experience, and no, I haven't had time to publish this either, but the mast cell patients who then get COVID and take the Paxlovid for 10 days, it's very clear in my experience, they have a much lower rate of rebound than those who are taking it for 5 days.
And then if there's a coactivity of the viral load creating more spikes around, and those spikes are a trick key to the toll-like 4 receptor, and that activates mast cells, and that activates endothelium, and that activates monocytes to create nets and microclots. Your antecedent sort of umbrella piece is getting the viral load down so it doesn't clip into the TLR4, and quieting inflammation or quieting antagonizing TLR4, which you could do with curcumin and metformin and a slew of things, or in the LDN and a number of the things you have listed. And if you had the antihistamine to stop the activated mast cells from the effect of that, it's 3 layers downstream. And Paxlovid's for 2 courses would be $2,600, and an over-the-counter antihistamine and metformin would be about $15.
Yeah, no, it's a standard principle of medicine, get to the root of the cause whenever possible. How do you treat DIC? Anti-clotting drugs, it's a Band-Aid, it's getting to the cause of the DIC that is what you really need to do. So if the virus is a hell of a trigger for these for uncontrolled dysfunctional, or I should say insufficiently controlled dysfunctional mast cells. So kill the virus. If you want to tack on some other mast cell targeting treatments, be my guest. They may well be helpful for understandable reasons, but if you're actively infected, kill the infection. Now, to be fair, there are occasional patients who find they literally cannot tolerate Paxlovid because it's available in only one formulation, and sometimes the excipients in there are big time reactions to one or another excipients. But in my experience, those are pretty rare patients. And more commonly, when a mast cell patient is having an adverse reaction to Paxlovid, it's a tolerable reaction. They can tell that it's triggering them, but they can also tell it's wiping out the virus. And so they tolerate whatever the adverse effect is while they go through the 10-day course of. They may even temporarily step up their mast cell targeting treatments to try to control the reaction, but they still got to take the damn, virus drug
quash the
for 10 days.
inflammation, and clean up the mess it causes. Absolutely.
Yeah. I cannot believe there are still 80 people hanging out there 2.5 hours, no, 3.5 hours into this.
Yeah, so we've got 36 people still in, so that I don't know if we've got 80 still
I'm
overall,
seeing
but we got
80 on my screen.
whatever. Yeah.
I think
However, I mean, there's still
3 may be blurred to 8 on your screen.
Oh, I see. Yeah, I call up it's 36 now. I'm saying I don't know why one screen is saying 80 and the other is saying 36.
Yeah, we've
Well,
had a
I'm
little
still
bit of a
impressed
dip.
that 36 people are hanging in here 3.5 hours into it. Kudos to you folks.
We were just going to kind of remind you about the time, about like how long it's going. We did have quite a few drop off in the last half hour, so I think they were starting to, kind of it gets a little bit long. But so we'll have just like maybe 1 or 2 more questions, and then we might be wrapping up, just because it is a long session. It's great information. So I think Isabel was going to be coming in to ask a question next, and then we've got one more at least after that if we've got time.
All right, so the next question is, do you find any difference in efficacy of medications between males and females? And is there any variation in response with the time of menstrual cycle?
Yeah, I think I briefly mentioned earlier in the presentation, and may have also mentioned it last weekend, that there's no question that estrogen is a molecule, a signal that can further activate mast cells. And many women with mast cell disease, they see clear worsenings of their mast cell driven symptoms in sync with the rises in estrogen through the menstrual cycle and during pregnancy. And with regard to likelihood to respond to a given treatment, sex-based differences in likelihood to respond to a given treatment, I can't say I've seen any of that yet. Maybe it's there and I'm just missing it because of the complexity of all this, but I haven't gotten the sense yet that, say, cromolyn is more likely to work in a man than a woman because the woman has more estrogen that's riling up her mast cells more. I wouldn't be surprised if there are some patterns like that with at least some drugs, but I haven't figured out any of those patterns yet. Sorry, can't help you with that. I mean, let's be clear, there's a well-recognized difference in the prevalence of this disease being diagnosed in the male versus female population. Multiple studies, very consistent, 4 to 5, 4 to 1 male to female, maybe as high as 5 to 1. I'm sorry, the other way around, female to male, 4 to 1 female to male, maybe as high as 5 to 1 female to male. But and probably some of that difference is being driven by the estrogen. But there are also the psychosocial factors that we talked about in the talk last weekend that may account for some of those sex-based differences in the rate of diagnosis.
All right, so thank you. I'll ask one more question and then Isabel's going to be wrapping up after that, after you have a chance to answer it. And so this one is from another anonymous attendee. So could the finding of colonized STEC Shiva toxin producing E. coli be driving factor of an MCAS GI issues? This was an accidental finding. A PCR test was done on stool because positive blood in the stool and a very high stool calprotectin. Endoscopy and colonoscopy will be done soon. There will be a biopsy for mast cells. Any recommendations generally?
Well, I don't know what to say about that other than to just make the obvious observation that mast cells are a normal part of the human body, and their dominant role in biology is the first line of defense. I mean, they normally activate in any infection. We need our mast cells to activate to help manifest a robust response by all the different pieces of the immune system against any infection. The problem is how much excessive activation enters the picture when you have fundamentally dysfunctional mast cells, mutated mast cells that are being triggered by an infection or anything else. And at that point, all bets are off as to how dysregulated the activation, how wildly inappropriate the reactions by those dysfunctional mast cells might be. And then all the downstream consequences, of course, of that inappropriate activation. So could a Shiga toxin and a Shiga infection be driving some extent of mast cell activation? That's easily possible. I'd expect that infection to be driving mast cell activation under normal circumstances, but If the patient has MCAS, then it could easily be that such an infection might drive a much wider range of troubles in that patient than you would expect in somebody having that infection who doesn't have a mast cell disease. And if you're trying to figure out whether that patient really does have a mast cell disease or not, go take a history, a very thorough history. And if you find issues that are consistent with mast cell activation dating back well before they ever could have developed that infection, then it makes it much more likely that they've got a long-standing MCAS, and now they've got another issue that is for sure a significant aggravating factor. So you're going to have to address both issues. You're going to have to deal with the infection, and you're going to have to, deal with the mast cell disease as well. Hopefully the infection you get rid of, you cure that, it goes away, but you're going to have to be dealing with the mast cell disease for the rest of the patient's life.
All right, thank you so much. Thank you to everyone who attended and stuck it through the end. Thank you so much to our panelists for being here today. And more than anything, thank you so much, Dr. Afrin, not only for today, but the incredibly generosity that you have given us with your time. And I am sure that not just those who are attending and attended the previous ones, but all of those who are going to be able to watch the recording and look through your slides will greatly benefit from this information. So we are beyond thankful for your generosity. And thank you, everyone, for making this possible.
My pleasure. Thank you again very much for the opportunity. It's been great. So have a good weekend, everybody.
Thank you. You as well.
Bye.
Bye-bye.